support human partnerships. I understand how you are feeling. I believe I can help. I hope we can beat this, should be the words which can empathize patients. What matters to patient and families is not just what the doctor says, but how he says it. Few are the changes in medical assessment like OSCE, OSPI, OSLR, MiniSec, CBT, feedback, and the questionnaires. Advancement in technology. The trends of classroom and bedside teaching has left a far away with new technologies including problem-based learning, competency-based learning, team-based learning, simulation, flipped classrooms, and many other. The emergence of e-learning, formats of learning such as online courses, has created a hub in medical education. This has engaged and imparted millions of students in virtual classroom, changed teaching and learning methods, and redefined the traditional boundaries in the universal education system. These new and attractive digital learning platforms, as well as multimedia and social media tools, are widely accessible and easy to integrate into teaching curriculum. Online study platforms like massive open online courses and small private online courses have also gained attention. The utility of media platforms in medical education has also significantly evolved. Methods for self-directed learning of audio lectures with associated slide images via the internet has now developed and described, and these media could also be saved for later use. So the final take-home message, the uncertainties that tomorrow's physician will face are in fact a reflection of the uncertainties we all face as people. Modern medicine is indeed a partnership between the physician and the patient, equally in lieu of the emerging trends. Just the soul of medicine is on trial. Medical education must become more of a partnership between students and faculty, between medical schools and the community physicians, and between medical schools and the communities, and preparedness and dedication to serve the society. Thank you so much.
We're honored to have ma'am share her thoughts. Thank you, judges. Thank you to everyone for your participation. Next, I would like to invite Dr. Sunita Tripathi ma'am, organizing president of EZACBICon 2024, to present the tokens of appreciation to our esteemed chairpersons. Thank you, ma'am. A very warm welcome. Thank you, ma'am. A very warm welcome to our guest speakers, Dr. Pratitidas ma'am, Dr. Pradeep Kumar Patra sir, Dr. Jayashree Bhattacharjee ma'am, delegates, and all of the medical professionals present here. We now welcome everyone to our upcoming session, which features an expert oral presentation by a respected guest speaker, Dr. Prakriti Das, on recent advances in diagnostic biochemistry shaping the future of healthcare. Please Join me in welcoming our esteemed chairpersons, Dr. Neelam Mehta ma'am and Dr. Kavita ma'am. Ma'am, kindly introduce our distinguished guest speaker.
Good morning, one and all. I am privileged to introduce the guest speaker, Dr. Prakriti Dash. She is a highly respected academician and researcher, currently serving as an additional professor in the Department of Biochemistry at AIIMS Bhubaneswar. Her academic journey began with an MBBS degree from SCB Medical College, Cuttack, followed by an MD in biochemistry, showcasing her commitment to deepening her expertise in the medical sciences. Her professional journey started as an assistant professor in 2008, and through years of dedication, she has risen to her current position at AIIMS Bhubaneswar, a prestigious institute known for producing world-class medical professionals. With a career that spans over 15 years in medical education and research, Dr. Dash has made significant contributions to the field of biochemistry, particularly in cancer diagnostics, with a focus on biomarkers such as prostate-specific antigen in breast cancer, endocrine disorders related to pregnancy, and preeclampsia. She has authored numerous peer-reviewed papers in top-tier national and international journals, contributing vital knowledge to the global medical community. Her work on subclinical hypothyroidism in pregnancy and her groundbreaking research into the immunological and biochemical aspects of diabetes have established her as a thought leader in her field. In addition to her academic and research contributions, Dr. Dash has received several prestigious awards, including the Dr. C. Sita Devi Award, and was the top performer in Obs and Gynae during her academic training. Her reputation as a scholar is further underscored by her affiliations with several key professional organizations. She holds her life memberships with bodies like Association of Clinical Biochemists of India, Indian Association for Cancer Research, the Indian Thyroid Society, and many others. Beyond her publication, Dr. Dash has been involved in a number of high-impact research projects, including studies on the antioxidant properties of curcumin and its potential role as a chemoadjuvant in cancer treatment, as well as investigations into the inflammatory markers associated with preeclampsia. Her current projects include using machine learning to refine the accuracy of biochemical markers in clinical diagnostics, a testament to her forward-thinking approach to integrating technology and healthcare. Dr. Dash has also contributed to the academic community as a PG thesis guide and a researcher in several funded projects. Dr. Prakriti Dash's work continues to make a lasting impact not just in the classroom and the lab, but also in the lives of patients who benefit from the innovations she and her team develop. Her multifaceted career combines the rigor of a dedicated academic, the curiosity of an innovative researcher, and the empathy of a healthcare professional deeply invested in improving patient outcomes. It is an honor to introduce Dr. Dash, a luminary in the field of biochemistry and medical research, whose passion and dedication continue to shape the future of medicine. Dr. Prakriti Dash, I welcome you, and the stage is all yours for the next 30 minutes.
Thank you, Dr. Neelam, for this wonderful introduction. I really feel very privileged, and I would like to thank Dr. Kavita and the whole organizing team for inviting me here to give the talk on this title, which actually I was thinking where to start and where to end. Because it completes everything that I have to say about clinical and diagnostic biochemistry. And I will just tell a small little thing before I start the talk proper, that when I was giving my interview for AIIMS Bhubaneswar in New Delhi, I was asked what I am supposed to do in biochemistry, like how I am going to help in biochemistry. That was what the panelists asked me. And I said I wanted students, if any MBBS students are sitting out here or the PG students, the students should develop that interest that biochemistry is not only a non-clinical subject as it has been said till now. That they should know that it has a long arena, it has a long area to cover, and where we play an integral part in diagnosis of diseases and also helping in the prognosis and monitoring of various cancers and other diseases too. So that was my idea, that students should come out of that idea that biochemistry is just non-clinical, they have to pass and go for the clinical years. So that was my response in New Delhi at that time. So I don't know how they were impressed, but anyhow I got the job. So today I will like to share some my own experiences about the recent advanced techniques in clinical biochemistry, diagnostic biochemistry. But when I thought where to start the talk from, I thought why not start it from colorimetry. That's the first basic thing that we know. So if we look at this slide, an introduction to modern biochemistry, what we have now, it is all about automation and robotics. We are no longer going for colorimetry. So I thought we will start from colorimetry so that we know where we were and where now we stand. So it is about automation, robotics. The next is molecular diagnostics, which has actually drastically changed the area of biochemistry. Without molecular diagnostics, right now we are not going to do anything. Whatever you go for any diseases, now it is the genes, it is the editing of the genes, it is the expression of the genes, how we can change it and all that. So it is all about now molecular diagnostics. Then mass spectrometry, of course, if we go from the DNA, we have to come to the RNA and then we have to come to the proteins. So without that, mass spectrometry, also we are going for mass spectrometry and POCT. Now POCT, like what I will be saying today also, POCT has helped in diagnosis of SARS-CoV-19 also. Like PCR was the gold standard, but they have also developed POCT devices to detect the SARS-CoV antigen. And bioinformatics, of course, when we come to artificial intelligence. How bioinformatics is going to help us. And all these things are now integrated for personalized medicine. Now, one by one we can discuss about it. I'll just try to touch all the topics. So if we are coming to personalized medicine, I will also tell about my own experience for personalized medicine, like how we the biochemists have helped the clinicians in designing the drugs for a particular patient and how they have improved. Like I will tell an experience of a patient who was surviving for 10 long years with stage 4 cancer. And the cancer was lung cancer with brain mets when the person was identified. But thanks to this personalized medicine, thanks to the mutation detection, that the person was able to live for 10 long years, where all other institutions from India till abroad till USA had said that the person may not survive more than 6 months. So that is the beauty of the diagnostic biochemistry and leading to personalized medicine. So like now what I said, from where we have started, what we started. When I joined PG in biochemistry, because I really didn't remember what I did in undergraduate time. So when I joined PG, the first thing I saw was the colorimeter. And I would like to say also that sometimes even we were not able to run the samples in the only sole autoanalyzer we had in SCB Medical College at that time. That was a very primitive type of autoanalyzer at that time. So even we used to take the blood sugar results in colorimeter. And the technician sitting there, he would be looking at the color of the reagent of the sample and the reagent and will say, Madam, aap likh do, isme 330 milligram percent glucose hai. So I would be like, how can you tell that? You should measure it. No, madam, pata hai, ye itna hi hoga. So that was the beauty of the colorimeter. And then the era of autoanalyzer was just beginning. I won't say beginning because it is from 1950 that the autoanalyzer went into the market. But in Odisha and in SCB Medical College, it was around 2000 when the autoanalyzer had come. And it was of the very basic one, like the batch analyzers. So we used to do in that. And very often it used to go out of order and we used to go for colorimeter assessment again. And then all of us are acquainted with this, that is the spectrophotometer. So there was one very old, like the institution, my institution SCB is around from the British era. I think the spectrophotometer was also from the British era. So we used to do certain PG experiments in this. So this is how, where we were some years, few years back, like 20 we came to this, like we had a semi-auto analyzer, then of course we have this fully automated analyzers which drastically changed the scenario completely with the advent of the auto analyzers. It really reduced the turnaround time and everything was very precise. Like the sample we take, when we take in colorimeter, we used to take it in an auto pipette, that may wrong, that may be wrong, that may not be calibrated properly. But when we came to auto analyzer, we were really tension free because it measured everything, it took everything in its own stride. And it also reduced the manpower requirement. Now that is a pro, that is a con also. When we say that we reduce the manpower, that's okay. But without the skilled technicians, because by that what happened, that the technicians gradually the number went down. So that was the really disadvantage we can say. And more disadvantage came when we came to the total automation in laboratory. Total laboratory automation or TLA. So we'll come to that. Now this is the auto analyzer. We all are very acquainted with the robotic arm and taking the reagent precisely, taking the sample precisely, running in seconds and giving us the result. Like we in our laboratory now, for almost all parameters, we have a turnaround time of around 20 minutes. Around 20 to 25 minutes, we are ready with the report to give it to the patient. So that was the beauty of the auto analyzer. That is how gradually we went forward. Then coming to, we have reached here. Now this is total laboratory automation, having the pre-analytical part, the connectivity to analytical part. In many laboratories right now also, like in my laboratory also, we are not going into total laboratory automation, we have not yet reached. But many high-end laboratories like many private corporate labs have incorporated this total laboratory automation, where the entry of the sample, reading the barcode, taking, decapping, and doing the centrifugation, and again sending it to the analytical part, everything is done automatically, like no manpower needed. And as this diagram is showing here, only one person is standing here. And that particular person is more than enough. If we put the samples here, automatically it will read the barcode will be also attached automatically, and it will decap, it will centrifuge, it will take the sample, it will take the reagent, it will analyze, it will show the results. Now only the part comes to the biochemist that we have to validate those results. Particularly that may not be the total laboratory automation is not able to do. So we are still safe, most likely, that still we are needed to validate the results. But I will be coming to artificial intelligence. So maybe will be also be refreshed. Let's see. So finally, as far as the clinical laboratory is concerned, we have reached till this stage. And many laboratories have automated. Now this total laboratory automation, where even the centrifugation part also, nobody requires to be standing there and putting the samples into the centrifuge and taking it off. So that part is also has been taken care of. Now this is what we are in the diagnostic laboratory. Then coming beyond that, like what I have been telling till now is the general biochemistry parameters, like our glucose, our urea, creatinine, or we can go for the tumor markers in chemiluminescence or electrochemiluminescence. Now beyond that, what are the diagnostic things we can do where we can think beyond the normal general clinical biochemistry parameters? So all of us are very well acquainted with PCR, the polymerase chain reaction, coming to NGS, which has revolutionized the molecular biology parameters, the NGS. Then liquid biopsy, which I will be telling a little bit more, because though exactly I am not working on liquid biopsy, which I am aiming to do in my future, but somehow I am into liquid biopsy right now. We have DNA microarray, that is how the gene are expressed. Now we can see which are the expressed gene, which are the overexpressed gene, which are the underexpressed gene. Then we have CRISPR-Cas9. I was talking to Patu sir. Patu sir is like my teacher, so on my way I was talking to him about CRISPR-Cas9. So that is also may not be diagnostic, it is more of a therapeutic tool for us, the CRISPR-Cas9, and of course the miRNA or the microRNA. So these are the now the advanced things that we are doing as clinical diagnosis. This is the diagnostic biochemistry. We are not talking about the therapeutic applications. Of course, once we do the diagnosis, they will go for the therapy, taking the laboratory to the bedside. So that will be doing further. So coming to PCR, now who doesn't remember this and who is not acquainted this? When we remember this part, we are really terrified. But what the PCR did at that time, we all know that. Now, how many times we all have given our nasal swabs and how we will be able to detect the SARS-CoV virus. So the real-time PCR, we have applications for PCR for many things. Like everything, we need the amplification of the DNA, and we can amplify the RNA, and we can go for that. I have particularly chosen this SARS-CoV because this is the now the most current thing that we have overcome. Probably we have overcome if the virus doesn't decide to challenge us again with some new tests or some new facets. So till that, we can say that we have overcome this. So at that time, we all have gone through this, like when we have given our nasal swab, then RNA was extracted because, and then with reverse transcription, because SARS-CoV virus was an RNA virus, so with reverse transcripted, the virus RNA was, cDNA was amplified, and the CT number was calculated, and then it was validated. Like, if the virus is present, then it will give a higher signal with a lower amplification cycle. That is how it was diagnosed at that time. So this PCR, this is the thing which were very much in use during the SARS-CoV-19 virus infection, which literally saved our lives at that time. So apart from many uses of PCR, this is one of the most important one for which I chose to say about this. And coming to the NGS technologies, as I said, because once this NGS has come into once the NGS has come into picture, many of the other techniques have gone into obsolete. But NGS right now are not present in all the laboratories, but many, almost all the high-end laboratories are now have next generation sequencing techniques. So what is the advantage? Like gene sequencing, all of us must have read in our undergraduate careers as well as postgraduate careers, that is the Sanger sequencing. We all were acquainted with that. Now what is the major thing that we are doing with the NGS right now? It can sequence the whole genome at fraction of in few seconds. That is the advantage. Because what we are doing previously were we are sequencing fragments of the DNA. Right now what we can do, the whole genomic sequence of a complete of a person can be done with this NGS sequencing within few minutes. So with that we can know the expression of all the genes of that person. If there is a mutation, we can see it immediately because we don't have to scan for particular gene. Every gene, and that is usually compared with a controlled human genome sequence. That is what is the basis of this NGS. NGS itself is a full-on topic for discussion. So I'm not going to the complete nitty-gritty details of the NGS technology. So what I can say is that within minutes, the whole genomic sequence of a person can be done. And we can identify all the genes that is present in that person. Whether any of the gene is mutated or it is not mutated can be known. It will be compared with a control genomic sequence. So how it is being done. So that is why NGS is now the in thing for us. We can diagnose anything, any genetic abnormalities with the NGS technology. And just briefly telling it, what we can do in what is done in a NGS is a sample is sent to them and the specimen is extracted and there is a library preparation. Now what is a library? What is the library preparation here? Briefly I can say that suppose
1% is the genes. In our whole DNA, only 1% are the expressed genes. And in that 1%, we have so many of genes. So if what is abnormality in me can be detected immediately. And then we can send the report to the physician who has sent the sample to us. So that is the diagnostic. But this is the gene which is defective, and this is how the patient is going to be affected or is affected. Coming to the liquid biopsy, which is a very interesting thing now, that biopsy, as all of us know, that we have need a tissue section for that. Every time it is not possible to take a tissue section. Am I right? I think everybody will agree that. Suppose we have a brain tumor. It's not very easy to open the brain and take the tissue biopsy. So it's a very difficult thing when the brain tumors we are discussing about. Now what is that liquid biopsy? It is circulating in the blood. So what is circulating? It can be a circulating tumor cell, like, and that is the basis of metastasis also. Let me say that if the circulating tumor cells means the cells are getting detached from the tumor and they are circulating in the blood. Then it can be a cell-free DNA also. Cell-free DNA can be from a tumor, can be from a normal cell also. So how they identify the cell-free DNA, that whether it is from a tumor or it is from a normal cell, that I will be saying. Then we can have a circulating tumor DNA. Cell-free DNA and circulating tumor DNA. Now the circulating tumor DNA is only from a tumor, which definitely must be having some abnormalities. That we all know. Correct? So this circulating tumor cells, they come from the tumors, they are released from the tumors, and that is the basis for metastasis of this tumor. When they are released from the tumors, they will go and dislodge in various tissues and cause metastasis. So we need to detect that. We need to detect that, and we need to say to the physicians that yes, this person may land up in metastasis very soon. So that is the beauty of the liquid biopsy with us. And similarly, the cell-free DNA. As I said you, the cell-free DNA can be from a normal person, normal cell, or can be from a tumor cell. Then we come to the circulating tumor DNA. Now, how do we see this cell-free DNA and circulating tumor DNA? The tumor DNA will be having some epigenetic marker changes in it. If we all know, the methylation of the histone is a epigenetic change. So that will be identified in case of the circulating tumor DNA. So we can say that this is a tumor DNA, this is not a normal cell-free DNA from a normal cell. Okay? So that is how this beauty of this liquid biopsy is there. Then it is easy. Why it is easy? Because we can get the blood sample very easily. We don't have to go to the tissue biopsy. We don't have to be a very invasive procedure we need not do. So we can get the blood sample and we can get it repeatedly. Suppose someone is going for a histopathology tissue section. Well, I am not downgrading histopathology. I am not saying that they don't have a role. Of course, that is the gold standard till now. Why that is the gold standard and why this liquid biopsy is still lagging behind, I'll come to that. Okay? So, it's very easy. We can take the blood. We can identify the cell-free DNA. We can identify the circulating tumor cells. We can identify the circulating tumor DNA. And repeatedly we can do that. आज आ जाओ, अगर नहीं मिला तो कल आ जाओ. We can take this blood sample, isn't it? We can do that. And there is the sample heterogeneity problem is also not there, which is there in a tissue biopsy. Sample heterogeneity problem is also not there. Then what is the problem here? The problem is the minimal thing, the minimum cells that is present in the liquid, in the blood. It is not very abundant. Like as it is ideally said, that it is like searching a needle in a haystack. That is the problem. The stuck actually, because as we all know, chemiluminescence or electrochemiluminescence is more advanced, more sensitive than ELISA. I was stuck. I had bought the kits and everything, and this was in 2005 and 6 when I was doing post graduation. So I was really like, "Ki, what am I going to do now?" And so I was going through literatures, ki what is the minimal level of PSA in females. Already I have challenged the biochemist that yes, PSA is present in females. So ultimately I could find out from literatures that electrochemiluminescence chemiluminescence was able to detect the PSA in a lower, it has a high sensitivity with a lower detection limit. So then there was only one E-CLIA at that time in Cuttack, and I took the help of the E-CLIA, and luckily I could find out PSA and I could complete my thesis at that time. So as now E-CLIA is very common, chemiluminescence is very common, and we can identify the minute to minute quantity proteins also with the help of this advanced technologies. Similarly, I am really hoping that liquid biopsy will be very much in our hand very soon, and we can increase the sensitivity, and then very nicely we can say, and when a tumor is present, before that some tumors are very silent killers like the lung cancer, so they start shedding the tumor cells very early, which is not able to be diagnosed. And usually if you find out the statistics, lung cancer patients usually present with metastasis even before the primary is diagnosed, because primaries usually remain silent and the metastatic tumors are first diagnosed. So if this liquid biopsy can be coming into play very quickly with a higher sensitivity, then probably we can prevent this. And that is what the diagnostic beauty we can have with liquid biopsy. So DNA microarray is even another technique where the gene expression can be studied. So not going to the details of the technology right now, but what you can see that it has got a array of chips where the RNAs are first utilized, either DNA or RNA, and they can be put into these arrays, and there will be probes and biosensors which can detect that which are the genes expressed, which are underexpressed, which are abnormally expressed, that is the genes are mutated. So usually what we can see here is we can detect abnormal protein expression, because ultimately the DNA to RNA to protein. So whatever the proteins are there, they are the causes of all diseases. So this DNA microarray are really helping us to know that yes, there is a mutation, and what is the mutated protein, how far it is expressed in that person, and how it is causing the disease. So this is another one of the diagnostic utility, but as I have said, once NGS has come, then probably the importance of these techniques will go away. Because with NGS, we can very well say that yes, this is the mutated gene and this is being expressed. And DNA editing, CRISPR-Cas9, here this is the technique where we cannot say that this is actually a diagnostic thing, this is more of a therapeutic application. Professor Patro will be a more suitable person to talk on this. So what I think we all know about the RNA editing. That is a very common question which is asked to MBBS students. The RNA editing and the FOB100 and FOB45 RNA editing thing is there. So like that, here is a gene editing. So what CRISPR-Cas9 is doing, CRISPR is a gene editing technique with a endonuclease which is a Cas9 protein, and it has got a guiding RNA strand. So what it does actually, it will remove a gene and put a normal gene in that, or it will remove a defective fragment and put it there. So this is like taking out something which is defective and inserting a normal thing in that. So right now the experiments or the studies are mainly on cystic fibrosis and sickle cell anemia. These are the two diseases, and Duchenne's muscular dystrophy. So these are the diseases where this CRISPR-Cas9 is being now studied, and things are looking great with this, where only when they have seen that when they can take out the defective gene and they can insert the original new one, then the person is actually improving. Even if they are not putting the original one, only when they are taking out the defective fragment also, the persons are improving in their life. So this is how this CRISPR-Cas9, but as I said, instead of more being a diagnostic utility, it has more of a therapeutic application, the CRISPR-Cas9 technique. go to any journal, you search any paper, microRNA as a diagnostic tool is very much into play right now, because microRNAs are really something in our hand, and we are also using it therapeutically right now also. So these microRNAs, they are actually gene silencing elements. So when the microRNAs, there are certain microRNAs which are particularly expressed in certain cancers or certain diseases where they are able to silence a particular gene. So presence of that microRNA, when they are diagnosed, they can help us in diagnosing that particular cancer, or not only in cancer but also in diabetes, in preeclampsia, in whatever disease you find out, they are now studying microRNAs. And when also these microRNAs, like the CRISPR-Cas9, we are all in CRISPR-Cas9, we are directly going to the DNA level. But here in microRNA, what we can do is we can give the microRNA and silence a defective gene. So that is how this is helping us. So microRNA, not only it has diagnostic therapeutic applications, but more so it is now diagnostic. But it has been found that in certain cancers, these microRNAs are overexpressed, and they are actually inhibiting certain pathways for which the tumor cells are able to grow. So when we can diagnose, we can identify these microRNAs, we can help in the diagnosis of that particular cancer. And what is the prognosis of that particular cancer? If the microRNAs are very much abundant, then obviously that cancer can have a very worse prognosis. That is how these microRNAs can help us in a diagnostic tool. So if the current window, the traditional biopsy-based diagnosis, so these are the things we can see, normal pre-cancer. But when it is a microRNA thing, we can just take any swab, any sample, and go for the microRNA detection in them. We need not have a tissue biopsy. Why I am emphasizing on liquid biopsy and microRNA as a diagnostic tool? It is because of the easy availability of the samples. When the sample, because for tissue biopsy, my own experience with the lung cancer patient, I will be saying you that the patient was detected with stage 4, and the original primary cancer was sitting as a pinhead, as I was told by the oncologist at that time, that it was a pinhead, and it was sitting at the bifurcation of the middle bronchus. It was not causing any symptoms. The patient was absolutely symptom free. But when what symptoms he developed? He developed loss of memory, he developed severe headache, and when the investigations like CT, MRI and all was done, he had a metastatic brain tumor, and the primary was sitting silently in the lungs. So why that happened? And even the patient was diagnosed, we could not take a proper biopsy specimen from the lungs because of unapproachable site of that lung cancer patient. So the liquid biopsy or the diagnosis based on microRNA, these things are now the future of diagnostic biochemistry. Definitely the future of diagnostic biochemistry, which I'm sure is going to change the whole scenario of the diagnostic part, particularly for the cancer patients. Particularly for the cancer patients. So with all this, with the molecular biology, like the NGS, like the CRISPR-Cas9, or like the microRNA, now if we know it's a mutation, what we are going to do? Okay, the person has mutation. So every time this CRISPR-Cas9 gene editing may not be possible. So what next? The mutation is giving an abnormal protein. So what we can do is, now we are going for personalized medicines, the tailor-made medicines. So the tailor-made medicines, they will only go and get attached to that particular protein, which is abnormal here. So mostly, again coming to the case of lung cancer, there are a panel of genetic markers right now. So when there are various mutations like the EGFR mutation, the epidermal growth factor receptor mutation. This is one of the most common mutation associated with non-small cell cancers. So when we know that this is the EGFR is mutated, there are antibodies to block this abnormal EGFR receptor. So when that abnormal EGFR receptor is blocked, obviously the whole pathway is coming to a standstill and the tumor cells die. Yes, of course, why we are not very successful still with the treatment of these cancers? Because the cancer cells are more active, more intelligent than us probably. They are very intelligent. And we know there are various types of pathways, various types of molecules activated in a cell, and particularly in tumor cells. So, एक दरवाजा बंद किया, वो दूसरा दरवाजा blocking those particular abnormal proteins or receptors. Okay. One example I can give is the programmed cell death and programmed cell death ligand 1 protein, PD1 and PDL1 pathway. Now this is one of the pathway where there is a immune tolerance given to the tumor cells. This pathway is normally present in our body. Of course, it must be doing some good to us, otherwise why it will be present and why God will be keeping it there. So this PD1, PDL1 pathway actually is a immune checkpoint. Immune checkpoint. It prevents autoimmune disorders and most importantly in pregnancy. It protects the fetus because the fetus is an abnormal protein for the mother. Now how the fetus can be an abnormal protein? Because the fetus has got both maternal and paternal antigens to it. Okay, so in that sense the paternal antigens is not normal for the female, for the mother. So the mother immune system will always try to destroy the fetus. And this PD1, PDL1 pathway actually protects the fetus. That is one advantage of this PD1, PDL1 pathway. It also prevents our body from various autoimmune disorders. And it also regulates the formation of T regulatory cells inside the human body. And T regulatory cells are the key molecules to protect the body from autoimmune disorders. It actually regulates the immune system. Then what is the disadvantage? Why I am saying this here in personalized medicine? PD1, PDL1 pathway are usually overexpressed by the tumor cells. So what they do, and that can be identified. We can diagnose whether we can identify whether these PD1, PDL1 molecules are overexpressed in the tumor cells. Now why, if they are overexpressed, the tumor cells take advantage of this PD1, PDL1 pathway. What they will do, they will escape from our own immune system. Otherwise, we would have killed our tumor cells because tumor cells are abnormal. When they are abnormal, with the normal immune system, we will be able to kill the tumor cells. Then why we are not able to do that? Why certain people are not suffering from cancer while some people are suffering from cancer? Because some cancers overexpress this PD1, PDL1 pathway and they escape from the tumor mechanism. So now what happened? Now we have personalized antibodies against this PD1, PDL1 system. And that has been used in certain cancers, in oral squamous cell cancer, in non-small cell lung cancer, in various cancers now it is being used, like nivolumab is one of the molecules which actually blocks this PD1, PDL1 pathway. So this is how our role we are playing, like we are able to identify whether this PD1, PDL1 pathway is overexpressed or not. And we give the report to the physician and they can now decide that yes, this person is going to take the advantage of positive or triple negative, and how the person is going to benefit. So this is the advancement beyond our clinical biochemistry lab where we have reached. And then this is cetuximab, imatinib. Cetuximab, as I have said, EGFR is a very common mutated protein in lung cancers. And this cetuximab is very widely used in lung cancers, metastatic colorectal cancer, and also in oral squamous cell cancer. And tyrosine kinase inhibitors, which are known as TKIs. Tyrosine kinase inhibitors, which is a secondary messenger, all of us know that. And when that is mutated, that is helping the tumor cells to grow uncontrollably. So these are all the precision medicines in market, in use now, and thanks to the molecular biologists, the geneticists, we have actually found out, yes, this is the defect here, and you can go for this medicine. That is how it has helped us. So advances in molecular diagnostics and genomics, next generation sequencing, liquid biopsy, CRISPR-Cas9 editing, microarray analysis, bioinformatics, finally leading to personalized medicine. So this part is now over. That's where we have advanced till now. And what more we can do? Now knowing the proteins, we know the DNA now, we know the RNA now, but we have to know the proteins, because ultimately the proteins which are creating the problem. So we can go for mass spectrometry for diagnosis, and automated gel electrophoresis and immunofixation. So these very other techniques biological fluids. So we can see this, that we can take anything of this body fluid, cell culture, or tissues and protein mixtures and do the ACH test, see that in the mass spectrometry, so that abnormal proteins we can identify, particularly in case of newborn screenings. In newborn screenings, when the patient is, baby is suffering from various diseases, so we can go for a mass spectrometry analysis of various proteins which are excreted or in the urine or in any other body fluids. So that is how it is helping us in case of the newborn screening. So mass spectrometry is a powerful analytical technique. We can quantify the known materials, we can identify unknown compounds. Sometimes we do not know what is the protein which is actually creating the problem. So with the known proteins, this mass spectrometry can identify unknown proteins and see that, yes, this is the protein which can be a problem here. And to elucidate that abnormal protein structure and chemical properties also. So once we identify an abnormal protein, we can identify the structure, we can elucidate the structure and say that, yes, this is the abnormal protein here which is actually causing the disease. So that is how the mass spectrometry is helping us. And automated gel electrophoresis with immunofixation, this is mainly utilized, as we are utilizing now, is to know the polyclonal or monoclonal gammopathies. So, and mainly in multiple myeloma patients. Also in early multiple myeloma cases, like recently we got a case where exactly the M band was not coming, but it was just before that, but it was an abnormal band. So it was just telling that maybe the person has started the secretion of the abnormal multiple myeloma protein. So this is the technique very widely used and in diagnostic biochemistry, and we are doing it also for the identification of monoclonal and polyclonal gammopathies. So this is the automated gel electrophoresis with immunofixation. Automated gel electrophoresis, we can only say what are the bands present, like albumin, globulin, and different bands of the globulin. But in immunofixation, we can say what is the type of light chains being secreted, whether it is kappa light chains or it is the lambda light chains, and what are the type of heavy chains secreted. So that is the immunofixation technique. We go for either only serum electrophoresis, where only albumin and various bands of globulins can be present, or we can go for immunofixation, where we can even identify what is the exact heavy chain and what is the exact light chain which is being secreted there. So that is, and we are right now we are doing this in our laboratory. Now the expanded RNA again, going away from the DNA, then RNA, then the proteins. Now what are the advanced techniques we use in our diagnostic biochemistry? Day to day all of us are using this. I think you also be using, that is high performance liquid chromatography. So which is still now considered the gold standard for HbA1c estimation. Though we are also going for negative immunoturbidimetric method in our laboratory for HbA1c. But anyhow, HPLC is always the gold standard, and also this can be used for for many inborn errors of metabolism. Mostly HPLC is being for many inborn errors of metabolism, and in our laboratory in AIIMS Bhubaneswar also, we are doing this for diagnosing inborn errors of metabolism. So this is one very advanced technique, not available in small laboratories, but of course in big teaching institutions and other corporate labs, we do have HPLC. So that is the more advanced technique, and of course flow cytometry. We cannot now ignore flow cytometry. So what is this flow cytometry? It is actually detecting each cell of our body. If we want, we can detect every cell of our body, whether it is normal or it is abnormal. The cellular differentiation. The cellular differentiation can be done here. So whether it is a cancer cells with abnormal markers, we can detect it. In HIV patients, what is the count of CD4, what is the count of CD8? That is the most common use of flow cytometry right now. That we can do. As my research projects went, that I identified T regulatory cells in preeclampsia. So that can be made into clinical use also, provided the cost can be, we can bear the cost, because these are costly investigations. So this type of testing can count your immune cells, identify cancer cells, classify cancer cells. So flow cytometry is the in thing now, and it is being now used for diagnosis. In AIIMS Bhubaneswar, we are doing it for HIV patients, and which and research projects on preeclampsia and other metabolic disorders. But for HIV, it is being regularly used, and we can, yes, we can use it for blood cancers, like leukemia, blood disorders, like paroxysmal nocturnal hemoglobinuria, and immune symptoms like inherited immune deficiency, HIV, and therapy monitoring. When we can study our own cells, definitely we can go a long way. So flow cytometry is the advanced diagnostic biochemistry technique right now. And we are lucky enough to have a good flow cytometry in our institute, and we are working on that. So this is my work on flow cytometry, as I said, that we identified the T regulatory cells and its counts, and we correlated with the inflammatory markers and the cytokines, because the cytokines has to play a major role in any disorder. And if we can see that, we cannot say that this is an immune disorder, this is a protein related disorder, this is a tumor cancer related disorder, because they are all interlinked. So these are the various things how we are attacking that with our diagnostic prowess. Like we can go for DNA mutation analysis, we can see how the abnormal protein is there, then we can go the how the cells are reacting to that, whether it is getting going for apoptosis or it are just going for more tumor development. So this is the whole diagnostic scenario by which we can finally curiosity is is a diagnostic tool for us with the help of nanotechnology, that is the nanochips. So the nanochips are actually there in the curiosity devices and they detect the samples. So with this nanotechnology, we have the SARS-CoV-2 detection. That is a gold nanoparticle based lateral flow assay for the rapid detection of antibody IgM generated against SARS-CoV-2. And this is in use. So taking the swab, doing the PCR is the gold standard. course, that is a single-centric study, so the forum is open, and I think every center should take up this and find out that whether it is the time to revisit the AST-ALT range. So that was the beauty of machine learning. Otherwise, how we could have studied so much of data. So when we had so much of data, we just compiled those, put it into various algorithms, and really found out that it is time to revisit the AST-ALT reference ranges. And another one was a little bit different, like finding a better estimate of mean plasma glucose through machine learning regression modeling, a HbA1c based novel measurement protocol. So we actually went back. We went back that this can be having a dual, implications actually. From the just a random blood sugar value, we could find out HbA1c. That is the beauty. We didn't have to do HbA1c, which of course is a more tedious thing than just finding out random blood sugar. And if a person has HbA1c, we could pinpoint the random blood sugar value with this machine algorithm use. So that was the two small projects we have done till now. Of course, my colleagues are working on machine algorithm to find out a better biomarker for ovarian cancer. So they are working on that, and I think they have published also 1-2 preliminary reports on that. So they are actually trying to find out a panel of markers through machine algorithm which can actually identify a ovarian mass, whether it's a tumor or it's a benign mass. So that can be found out by the machine algorithm there. So finally, coming to the new era for biochemical analysis, we have automation and robotics, that is total laboratory automation. We have machine learning algorithms, that is the artificial intelligence, quality control, personalized medicine, imaging techniques, data analysis and interpretation. So these all together are taking us to the future, and of course the future belongs to NGS. I think so. That's my personal opinion, and maybe everyone will agree to that, that it is NGS, it is liquid biopsy, and it is artificial intelligence. So thank you again, and I'm glad that I'm here and I could speak my mind to all of you.
Thank you so much, ma'am. Due to time constraint, we will take questions later, ma'am.
Okay. I think I exceeded time. I'm so sorry for it. Thank you everyone.
Thank you, ma'am. Your insightful and expert presentation was truly valued. Uh, uh, Now we would like to request our chairperson to give a small token of appreciation to our respected guest speaker. I would request our guest speaker to give a small token of gratitude to our chairperson.
National Accreditation Lab, NABL and all being with them for many years, how many are able to do? NSG is a very costly thing. And how many in a developing country we are able to reach the common people? Is it really? In that liquid biopsy is very important, and few others like immunohistochemistry, because whatever is the genome, it is the protein. अच्छा, अभी जो humans part है, in 2003 Human Genome Project was, before 2 years it came, that Human Genome Project has come. We are attending the lecture of Dr. Brahmachari, who was CSIR Director General that time. And he said, he was one of them, Human Genome Project, and we are talking about pharmacogenomics. He was talking about pharmacogenomics. He said, इसमें नया क्या है? In olden days, our beds will come home, they will just feel the pulse, and they will give personalized medicine to everyone, not paracetamol to all fever. So is not that pharmacogenomics? And we all had to clap a lot for him. Another thing, when this Human Genome Project came, one of my PhD students came running to me. मेरा और जीने का मन नहीं है. मैंने बोला क्यों? E. coli gene and my gene not much different. Same. मैंने बोला इतना दिन यही पढ़ाया. You are working on transcription factor. You are working on epigenetics. And अभी बोला तू और E. coli same है. छोड़ दे अभी PhD जाओ. So that is the Human Genome Project, but we have come a lot from there. But I hope during our lifetime we see that it reaches our people, not just stays in the library.
Thank you, ma'am. Thank you, everyone. I would request everyone to remain seated as we will be commencing with our inauguration ceremony. I would now like to hand over the mic to Dr. Sindhu and Dr. Bikramaditya for our inauguration ceremony. Kindly remain seated. We will be starting with the inauguration in some time.
very good morning and a warm welcome to everyone gathered here for the inaugural ceremony of Eastern Zone Association of Clinical Biochemists of India Conference 2024. It is an honor to be in the presence of such esteemed dignitaries, distinguished guests, and bright minds from across the field of biochemistry. I, Dr. Sindhu R.
and Dr. Bikramaditya
would like to take a brief moment to acknowledge the pillars of support who have made this conference possible. Manipal Academy of Higher Education, an esteemed private university, has its roots in Manipal, Karnataka, dating back to 1953, when Dr. T.M.A. Pai founded Kasturba Medical College. Over the years, MAHE has grown into a renowned academic hub, earning India's Institution of Eminence recognition in 2020 and excelling in academic rigor, research, and experiential learning.
Since its inception on January 18, 1975, the Association of Clinical Biochemists of India has been instrumental in driving progress in clinical biochemistry. Through an array of initiatives which includes conferences, workshops, training programs, international collaborations, advisory services, and publications, ACBI has significantly upgraded healthcare and laboratory services, profoundly benefiting Indian communities.
Manipal Tata Medical College, nestled in Jamshedpur, Jharkhand, embodies a groundbreaking partnership between Manipal Academy of Higher Education and Tata Steel, becoming the first private-private partnership institution in the country. This visionary collaboration has catapulted MTMC to the forefront of medical education and training, boasting a comprehensive range of programs including MBBS, AHS, and PhD.
Transforming healthcare in Jharkhand since 1961, Mahatma Gandhi Memorial Medical College, Jamshedpur, is a pioneering institution dedicated to medical excellence. With a robust 540-bedded hospital and affiliation with Kolhan University, MGM inspires future generations of healthcare leaders, upholding Gandhian values of compassion and service.
We are all here to celebrate this landmark event, which serves as a platform for scientific exchange and collaboration in biochemistry and clinical research. With that, let us embark on this inspiring journey of learning, sharing, and growing together.
To commence today's event, I kindly request the dignitaries to grace the dais. I request Dr. Sunita ma'am and Dr. Kavita ma'am to escort the dignitaries on the dais. Our chief guest, Dr. Pradeep Kumar Patra, Vice Chancellor, Pandit Din Dayal Upadhyay Memorial Health Sciences and Ayush University of Chhattisgarh. Dr. Rajiv Ranjan Sinha, Secretary of Association Clinical Biochemists of India. Professor Rajiva Dwivedi, Director, Manipal Tata Medical College. Our guest of honor, Dr. G. Pradeep Kumar, Dean, Manipal Tata Medical College. Dr. Lakshman Lal, Chairperson, Eastern Zone ACBICon-24. He is also the ex-Director Medical Education of Jharkhand. And we have Dr. Sunita Tripathi, President of the conference, Professor of Biochemistry, and Dr. Kavita Rasalkar, Organizing Secretary of the conference, who is also the Professor and HOD Biochemistry of our college.
Thank you, dignitaries. Let us extend a warm welcome to all the dignitaries on the dais with a bouquet. I request our Dean, Dr. G. Pradeep Kumar, to kindly present a bouquet to our chief guest, Dr. Pradeep Kumar Patra. Sir, I also request you to present a bouquet to Dr. Rajiv Ranjan Sinha. I request Dr. Rajiva Dwivedi to present a bouquet to Dr. Lakshman Lal. Sir. Sir, I also request you to extend a warm welcome to our Dean, Dr. Pradeep Kumar ji. Sir. Now, now I request Dr. Sunita Tripathi to present a bouquet to Dr. Rajiva Dwivedi. Ma'am. I request Dr. Kavita Rasalkar to welcome Dr. Sunita Tripathi. Ma'am. May I in turn request Sunita ma'am to welcome Dr. Kavita ma'am. Thank you very much.
To seek divine blessings and mark the auspicious beginning of this event, I invite all the dignitaries on the dais for the traditional lamp lighting ceremony.
Thank you, dignitaries. Now, it is my pleasure to invite Dr. Sunita Tripathi, President of EZACBICon-24 and Professor of Biochemistry at Manipal Tata Medical College for the welcome address. Ma'am.
Good morning, one to all. Honorable Chief Guest, Dr. Pradeep Kumar Patra, VC Pandit Deen Dayal Memorial Health Sciences and Ayush University, Chhattisgarh, respected guest of honor, Dr. G. Pradeep, Dean MTMC, Dr. Rajiva Dwivedi, Director Academic and of MTMC. And Dr. Rajiv Ranjan Sinha, he is the General Secretary of HEBI, and Dr. Lakshman Lal, he is the ex-HOD of Biochemistry, MGM Medical College. At the same time, he was ex-DMED of Jharkhand also. I welcome you all, sir. It is with great honor and heartful of gratitude that I welcome you all to this August gathering focused on the theme Advancement in Diagnostic Biochemistry, Shaping the Future of Healthcare. Today, we unite not just as an individual in our respective field, but as pioneer committed to transforming the landscape of healthcare through innovation and collaboration. It is a great honor for us to welcome our chief guest, Dr. Pradeep Kumar Patra, being a Vice Chancellor and having such a busy schedule. He has accepted our invitation on the day we sent him the email to him. He has an impressive track record in the field of biochemistry as an educator, as well as a researcher. He consistently responds with kindness and humility, always offering a positive outlook no matter the situation. We are delighted to have you with us today, Dr. Pradeep. I extend a warm welcome to our guest of honor, Dr. G. Pradeep, our MTMC Dean, whose leadership and vision have been instrumental in guiding our institution towards excellence in education and research. We are grateful for his wholehearted support for this conference. We are honored to have with us Dr. Rajiva Dwivedi. He is the director of our institution, and he always helped us in any of the functions or in the educational systems. I would like to thank Dr. Rajiv Ranjan Sinha, Secretary SEBI, for sparing his valuable time and constantly guiding us for this Eastern Zone SEBI conference. We are grateful to have Dr. Lakshman Lal here, ex-Director Medical Education, who has guided us and helped us physically and financially for the last 3 months for the success of this conference. Today morning, we had an excellent presentation by Dr. Pratati, and she has told that how biochemistry has advanced and giving support to the clinicians for the diagnosis as well as for the treatment in various cancer and other conditions. And in the next few sessions, we will hear other guest speakers who will explain other conditions which are prevailing in our country. This conference presents us with unique opportunity to share knowledge, inspire one another, and explore the potential of cutting-edge technologies and methodologies. Together, we can tackle the challenges facing in our field and harness our collective creativity to drive meaningful changes in the healthcare. I'm grateful to all the guest speakers who have come from such a long distance, and they have spared their valuable time to encourage our participants in this conference. I encourage each of you to engage openly in discussion and embrace the spirit of innovation that defines our work. Let us not only save the future of diagnostic biochemistry, but also ensure that our advancement translate into improved patient outcome and enhanced safety and quality of life of our patient. I would like to extend my heartfelt gratitude to our organizing secretary, Dr. Kavita, and her team, whose tireless efforts and dedication have been instrumental in making this conference a resounding success. I thank everyone for being here today. Your presence, participation are vital for our mission. I look forward to the ideas and collaboration that will emerge from this gathering. Let us make this conference an inspiring and impactful event. It is our proud moment to have two Pradeeps in this stage and today's occasion. Both of them have proved their name because both of them are serving for the society and for the community. So before concluding my talk, I would like to have one sloka. Deepo nashyante dhatang, धनोरोग्ये प्रयच्छति कल्याणाय भवति एव दीप्यो ज्योति नमस्तुते। दिया अंधकार का नाश करता है और आरोग्य तथा धन देता है। सबके कल्याण करने वाले दियों को मेरा प्रणाम। थैंक यू।
Thank you, ma'am, for the warm welcome. Now it's my great honor to invite our chief guest, Dr. Pradeep Kumar Patra, Vice Chancellor, Pandit Din Dayal Upadhyay Memorial Health Sciences and Ayush University of Chhattisgarh, to address the gathering.
Good morning, everyone. Respected Dean Sir, Dr. G. Pradeep Kumar, and the faculty director, Dr. Rajiv Dwivedi ji, and all the senior dignitary like Dr. Lakshman Lal sir, Dr. Rajiv Sinha sir, Sunita madam, Kavita madam, and our veteran professor Jayashree madam, all the guest speaker, delegates, and dear students. It's really a proud moment for me, because when Sunita madam asked me to come here as a speaker, later on I could know that she's making me chief guest, because so many veterans are there, and I don't know how I'll justify my duty. As a teacher, when I was coming for different MCI inspection, all of a sudden I was there in a Darbhanga Medical College inspection. See, Darbhanga Medical College, one of my professor, he is no more, Dr. B.C. Kar, sorry, that Dr. Kar, that is the Basu Kar. Dr. B.C. Kar is also my professor, he is also my mentor. And Dr. Basu Kar, he was the professor of SC Medical College. He was the student from Darbhanga Medical College as a MD Biochemist in 1964. But why I am sharing this? This is a very important event. When I came to the Darbhanga Medical College as a assessor, as a teacher, as a biochemistry teacher, I found all the Sunita madam, she is my senior from MBBS when I passed from Burla Medical College, Odisha. Madam was also my senior, she was from Burla Medical College. So I found her and I asked, where from your MBBS? Some Burla Medical College. So I told, do you recognize me? Obviously, so many students are there. So I told my elder brother, he was professor of surgery there, Professor E.K. Patra. Oh, Dr. Patras. So that is not the point I was to emphasize you. The point was, all these MD biochemist was de-recognized professor there. So all are crying and sir, hum log ko bacha lijiye. Kya problem hai? Ye to. So what happened? The problem was the Darbhanga Medical, my professor in 1964, he passed MD from Darbhanga Medical College. All the degree are de-recognized. So problem जो अंडा मुर्गी की खेल चल रहा था, MCI बोल रहा था कि कोई faculty recognize नहीं है, अरे वो recognize होगा तो ये recognize होगा. So that was all the note I found everywhere. All the assessor has written that these all the faculty are de-recognized for degree holder. So I discussed with the dean. He was from ENT, professor of ENT. So he told, how you help Dr. Patra? I cannot help, but I put a note. मैंने ये दोनों वाइस वर्सा है, एक को recognize करेंगे तो दूसरा recognize हो जाएगा. So let me recognize this college degree, then all will be recognized. So that is the way I met first after the MBBS Sunita madam, and Now she called me and she was once visited in different meetings and I saw. But I'm really thankful, Madam and your team, and I extend my gratitude and the Dean sir also. And I just talked Dean sir. He also served as a vice chancellor in the medical university. I am junior sir to you as a vice chancellor because I joined in March only. And because this is a very peculiar work, I think, as a vice chancellor in a medical university, there are so many complications Dr. G. Pradeep Kumar might have faced, and I am started this facing this. So that is not the point to discuss here. But important point is the biochemistry. So the biochemistry is not, as one of the speaker, Dr. Das was telling that, ये non-clinical subject होके नहीं रहा. I think all the students, those who are there continuing for the MBBS and in future they may join in biochemistry as a career, for the information, the biochemistry exactly, it is not in the field of the non-clinical branch. It's maybe sometime considered as a non-clinical branch, but practical is very advanced, very informative branch, and it is really helpful to the medical science in not only writing on the textbook or giving in some information in the Harrison textbook of medicines. Biochemistry is now very much essential. Dr. Das was also comparing with the artificial intelligence and the others in the radiology and biochemistry, what will be the future, whether the biochemistry will exist, yes, radiologist will exist, like this. But you see, जैसे हम एक्सरे मशीन और MRI को कंपेयर करते हैं, X-ray cannot be replaced by the MRI, but there may be advanced information may be there, but it is a beauty of the science. The primitive knowledge cannot be replaced with. So like this, the biochemistry is now so advanced, though Jayasri Madam was telling about this, the next-gen sequence, how it helped, and she was giving the example of Samir Brahmachari, because we are working with this Samir Brahmachari Institute. He was the founder director, and then he became the CSIR DG and Secretary, Government of India. This personalized medicine and other things, you see, this knowledge was there. हमारा जो नाड़ी वैद्य थे, वो लोग पहले भी ये नाड़ी, feeling the pulse, they were diagnosing and they were prescribing the medicine, and it was very much particular and very much personalized. So it is not, need not to be हम NGS करें और हम personalized medicine prescribe करें. It is the knowledge of the clinician and the appreciation of the clinics, जो clinical acuity जो बोलते हैं ना, आजकल जो ये चीजें हम मेडिकल ट्रेंड में देखने को मिलता है, everybody is just when patients coming in panel of investigation they are writing, and after that they are deducing the diagnosis, and but that was not actually the aim of the medical teaching. Yes, diagnosis is the additive factor, but it is the clinical acuity and the clinical knowledge is very important to diagnose the and to treat the patients. I think so many clinicians might be there, they might be they will agree with me that the clinical knowledge is very important, and how much time you are giving to the patients. Our professor was teaching us, feel the pulse of the patients. That is the more important, how much giving time, because your patient is the great teacher. That is for the students I am telling you. The patients are the great teacher, and you have to give time to the patients, then only you will be the good physician. Prior to that, you have to be good human being also to become a good physician. That is for the students only, because we are teacher, always when your students are there, we always try to teach the students some information. So in the medical science, you have to respect to your patients. For that, you have to be very good human being. Then only we be the good doctors. So thank you very much and calling me and honoring me. And I wish there is a great success of this meeting. Thank you very much.
Thank you very much, sir. Now I request our Dean, Dr. G. Pradeep Kumar, Dr. Rajiva Dwivedi, Dr. Lakshman Lal, and Dr. Sunita Tripathi to felicitate our esteemed chief guest, Dr. Pradeep Kumar Patra. Thank you, dignitaries. Now we have arrived at a very special moment in today's inaugural ceremony, the official launch of the EZACBICon-24 conference souvenir. The souvenir serves as a memento of this prestigious event, capturing the essence of our gathering, key highlights, and the contributions of many esteemed professionals. I would like to humbly request our chief guest, Dr. Pradeep Kumar Patra, along with all the other dignitaries on the stage, to officially unveil the conference souvenir. Let's mark this moment of pride together. Ladies and gentlemen, please join me in applauding as we unveil the souvenir.
Next, I request Dr. Rajiv Ranjan Sinha, Secretary ACBI, to share his thoughts with us.
Chief guest for today, dignitaries on the dais, colleagues, and my dear friends, all students, on behalf of the Association of Clinical Biochemists of India, I welcome you to the East Zone Conference of ACBI. It is a very proud moment for me, because in 1979 I started my medical career as a first-year student in MGM Medical College. I was here for 4 months before being transferred to Ranchi in reallotment. But those 4 months were very happy for me, because that time MGM was MGM. I don't know about now. We used to have a really good time staying there, and I believe that MGM Medical College was also started by Tata Steel. It was the first college that they started because they had a quota of some seats in the college. After it was taken over by the government, that stopped. It is an honor to stand before you. Many of you are members of this association, but many you don't know what ACBI is about. So ACBI was formed on January 18th, 1975, when the then professor and head of biochemistry, Dr. Avdesh Sharan at Patna Medical College, he called biochemists from all the medical colleges of India. And you have to remember that that time biochemistry was under the shadow of physiology. And they formed this association under which all each and every person who is in biochemistry would become a member. And so we would get together, organize academic meets, do CMEs, do workshops so that people are abreast with the best of knowledge. ACBI was in 1977, after persistently badgering the Medical Council of India, they managed to separate biochemistry from physiology. That was in 1977. And we are members of various international bodies. We are one of the founder members of the Asian Pacific Federation of Clinical Biochemistry, International Federation of Clinical Chemistry. So these two major international associations, we are a major partner with them. Many of our members have profited by becoming our member because through us they apply for travel grants, scholarships to attend international conferences. We are going to have 2 international conferences just now. One from the 15th of October in Antalya, Turkey. Quite a few people have got scholarships there. Then 29th November, the Asian Pacific Federation will have its international conference in Sydney, Australia. I feel proud to say that many of our young members, they have got scholarships, full scholarships to present their work there. So we, as an association, we are a big family. We have gone through a lot of turmoil. We are still going through that. The medical, non-medical, and it is slowly dying down. But one has to understand that we are a branch which is in the middle of pure science and medical science. And we as a medical biochemist, I think that we are more attuned to the patient side. And we are doing so much for the betterment of society by, like Dr. Das said, personalized medicine. So we are at the forefront of diagnostics everywhere, whether people like it or not. And it is my belief that we should stand up in front of everybody, and you should be proud of the fact that you are the person who has given an arm, a missile into the hand of a clinician so that he can go about his business. Because today, I don't think there is hardly anybody जो कि नारी पकड़ के इलाज करे. It has become so common that people are not spending time looking at a patient. मरीज आता है, 15 जांच लिखाता है, जांच का रिपोर्ट आता है, दवाई लिखाता है. This is the trend, the sad truth about our society. People have forgotten how to interact. And on this point, I disagree with what the National Medical Commission is doing. They are making robots out of doctors. ये करो, MC करो, ये करो, वो करो, मरीज मत देखो. मरीज के तरह म्यूजियम में घूम जाओ, मरीज मत देखो. बेचारा बच्चा फाइनल MBBS, अब नेक्स्ट के बाद PG. तो when does he get the time to actually handle a patient? Many of us must remember, in our time it was, you have to do a senior house job and then only you can apply for PG exam. So those were the time when we got our hands dirty. You are talking about collating of data and AI. It is in the field of commercial biochemistry. There are software companies which have data for the last 50, 60 years. And if somebody gives a sample, they do a one blood sugar, they can give the next blood sugar without spending money. They do a TSH, they can give you T3, T4 without spending money. This is commercialization on the bad side of AI. And this is what they are doing. Many members have complained to me, sir, I am doing something for 200, X lab does it for 20 rupees. What do? They are using AI. So AI is not hunky-dory. So we are trying to get things in order. Most of you must have heard about the EQS program being run by CMC Vellore. It was in 1977 that the executive body decided that we should have a quality control program. We should have a program by which patient and the hospital can trust our reports. Dr. A.S. Kanagasapapati of Vellore, he started it, and today it's such a program that the governments of Tamil Nadu, Sri Lanka, they have put all their PhCs into that EQS program. Bihar, each and every new medical college and our medical college is with the EQUAS program of CMC Vellore. And it is NABL accredited. It is following all guidelines. So this is what, as an association, we have given to society. I think I've taken a lot of time. I'm very thankful to Kavita and Sunita and to meet you all. Many people are my friends. Many I have forgotten. जब से बिहार झारखंड अलग हुआ है, हम लोग अलग हो गए हैं. इधर से आना जाना बंद है. लेकिन it's very, thank you very much.
Thank you very much, sir, for your insightful words. Moving forward, I would like to invite Dr. G. Pradeep Kumar, Dean of Manipal Tata Medical College, to address the gathering. Sir, please.
A very good morning to you all. Greetings to you all from Manipal Tata Medical College. Chief guest of today's function, Dr. Pradeep Patra. Can you please keep quiet or go out and talk? This is bad manners. distraction. Chief guest of today's function, Dr. Pradeep Patra, the other dignitaries, Dr. Lal, Dr. Rajiv. There are two Rajivs, there are two Pradeeps and two Rajivs today. I was confused today when I came, why my name is seen on both sides of the board. So I would like to thank the Eastern Zone Association of Clinical Biochemists of India for giving this opportunity to Manipal Tata Medical College to host this conference in association with MGM Medical College, Jamshedpur. Dear friends, we are indeed privileged and honored to be part of this conference. As you all know, Manipal is one of the oldest premier institutes. Manipal is a place located on the west coast of India, nearer to Goa and Mangalore. Is a place. The first college started in 1953 in a PPP model. It's a first public-private partnership. We used to use the hospital of Mangalore Government Civil Hospital as a part of the training. So we have come a long way from there. Manipal became a separate campus, Mangalore became a separate campus. We have campuses in Bangalore, we have campus in Jamshedpur now. We have campus in Dubai, Antigua, Sikkim, Malaysia and other countries. Dear friends, Manipal Tata is similarly unique to Manipal KMC because this is the first PPP model again. This is private-private partnership. Tata's is a private organization, Manipal is a private organization. We became a deemed university in 1993 and an Institute of Eminence in 2020. One of the first private institute in the country to be honored with the Institute of Eminence privilege. And I'm very proud to say that my basic science teachers are doing very well. And in the last 4 years, I'm very happy to share with you the All India ranking of students' preference has come down. So we are one of the most preferred institutions in the region. And we hope to be the best in the eastern region in the next 3 to 5 years is our dream for us. As our Professor Rajivji said, biochemistry has grown a long way. When I was a medical student in 75, I joined. It was part of biochemistry. We were scared of dreadful Krebs cycle and other cycles. It was all Greek and Latin, you know, the benzene ring and so on and so forth. It was very, very scary for us to think of biochemistry. But dear friends, let me tell you, biochemistry is in every subject today. Without biochemistry, there is no subject today in the medical field. And very thankful to the faculty of biochemistry, professionals of biochemistry, for making biochemistry a very, very important component of medical care, healthcare. It was just blood sugar, blood urea those days, to highly advanced diagnostic tools today. Be it an inborn errors of metabolism or a targeted diagnostics. Today we have a patch where you can put on to see continuous glucose monitoring. It is because of the developments biochemistry has done. Earlier you had to go to a lab to get a check done. Today we've got the facility to do it at home. So biochemistry is very, very important component in the days of diagnosing of cancers today. Biochemistry plays a major role. So dear friends, please do not consider biochemistry, as you said, as a preclinical. It is a part and parcel of every subject of health sciences. There is biochemistry in pathology also, there's biochemistry in anatomy, there's biochemistry in, you name a subject, there's biochemistry somewhere or other is involved. You may say wondering where is biochemistry in anatomy and pathology. The stains what we use is chemistry and linked with the biology, it's biochemistry. So every person depends, as you rightly said, sir, without diagnostic tools, we will not prescribe anything. Apparently we may be looking healthy, but unless we do some screening for certain tests and certain diagnostic tools, we will not be able to detect. There will be several answers which are yet to found in the days to come, and I'll appreciate and request the fraternity to give adequate emphasis on the research methodology and encourage teachers. We are facing huge shortage of teachers. In view of the mushrooming of the medical colleges, disproportionate growth of medical colleges, teachers are in huge shortage. There is no college, probably I can say 5% of the colleges in the country have got full component. More than 95% of the colleges have got shortage somewhere or the other. They're not able to fully complement. And it is very sad, the Medical Council has reduced the number of teacher requirements to the medical colleges. How do you expect with 3 or 4 teachers to do small group discussions, to do lectures, to do practicals? It is highly impossible. And we are the people who run and guide the medical council, sir. When the biochemistry department is represented in the medical council or medical commission, please put adequate amount of pressure through these bodies that the faculty requirement is not adequate. We will not be able to do justice for small group discussion, for practical conducting, for conducting exams in a CBM curriculum. It is not adequate. It's high time the fraternity of biochemistry, like all of the fraternities, ensure and insist on a larger number of faculty requirements. Probably it's the time we should think of again how MSc PhDs can help us. I have a strong reason to believe they can contribute, if not to the clinical association of biochemistry, but they'll be able to help us in the laboratory, in the training of labs and colleges. So I feel involving them from 15% to 30%, the shortage of teachers can be reduced and students can be provided adequate training. Dear friends, I'm very happy to be part of this wonderful conference. I hope at the end of the day, we will be enlightened and enriched by the presence of such senior faculty, Madam Jayashree, for coming all the way to be a part of this. And आप थोड़ा ज्ञान बांटेंगे हम जैसे लोगों को तो हम ज्ञानी हो जाएंगे. Thank you so much, dear friends, for the opportunity.
Thank you, sir, for your encouraging words. I kindly request our Dean, sir, to officially declare the conference open.
Thank you very much, sir. To conclude this inaugural session, I request Dr. Kavita Rasalkar, Secretary of EZACBICon-24, to deliver the vote of thanks.
Good morning to you all. On behalf of the organizing committee of Eastern Zone ACBI conference, it is my privilege to propose the vote of thanks for this memorable inauguration ceremony. First and foremost, I extend my heartfelt gratitude to our chief guest, Dr. Pradeep Kumar Patra, for his gracious presence today in spite of important commitments elsewhere, and for also delivering an inspiring address. Your words have set a powerful tone for this conference, and we are deeply honored by your support. I would like to express our sincere thanks to Dean of our institute, Dr. G. Pradeep Kumar, Director and Associate Deans, for their unwavering support and guidance in hosting this conference. Your leadership has been instrumental in making this event a reality, and we are proud of you to have the institution's strong backing in advancing the field of clinical biochemistry. In absentia, we convey our deep appreciation to ACBI President Dr. Kannan Vaidyanathan, who unfortunately could not be with us today because of his commitments elsewhere. Nonetheless, his encouragement and contribution to the success of ACBI community are invaluable. Our special thanks to Dr. Rajiv Ranjan Sinha, Secretary ACBI, for his dedication to the association and his continuous effort in fostering learning and collaboration. Your role in supporting this conference is greatly acknowledged, sir. I also extend my sincere appreciation to Dr. Vanita Lal, ACBI Zonal Council member, for her guidance and active involvement in planning and execution of this conference. Your commitment to the success of this event has been remarkable. I also thank Dr. Lakshman Lal, organizing chairperson, for his immense support and also nutritious catering. Dr. Sunita Tripathi, the organizing president, a backbone of this event, who has led the department towards the success of this event. I also like to thank all our speakers who have made time from their busy schedule and are with us today to enlighten us. I thank the entire administrative team and all the departments involved in logistic and management of this event. Your hard work and attention to detail ensured the smooth running of today's inauguration and will no doubt contribute to the success of this conference. From venue arrangement to technical support, your efforts have been outstanding and we are truly grateful to your dedication. Lastly, to all the attendees and participants, thank you for being a part of this event. Your presence makes all the effort worthwhile, and we look forward to the fruitful sessions ahead. Once again, I thank you all for coming to the conference.
Thank you, ma'am. With that, we officially conclude the inaugural session of Eastern Zone ACBI Conference 2024. Let's look forward to an enriching and enlightening conference ahead. Thank you, everyone.
I request you all to be seated for the next session. Thank you for being patient. I hope you're ready for our next session. We are privileged to have Dr. Pradeep Kumar Patra, Vice Chancellor of Pandit Deen Dayal Upadhyay Memorial Health Sciences and Ayush University of Chhattisgarh, Raipur, as our esteemed chief guest and guest speaker, who will be presenting a comprehensive insight on sickle cell anemia on Chhattisgarh perspective. I now invite our esteemed chairpersons to the stage, Dr. Sunita Tripathi Ma'am, Professor, Department of Biochemistry, MTMC, Dr. Chinmay Das, Professor and Head, Department of Microbiology, MTMC. Please join me in welcoming our distinguished chairpersons as they introduce our honored guest speaker.
Good morning, everybody. Now I'm going to introduce our chief guest, and he is the guest speaker for us, Dr. Pradeep Patra. He is the Vice Chancellor of Pandit Deen Dayal Upadhyay Memorial Health Sciences and Ayush University, Chhattisgarh. Dr. Patra earned his MD Biochemistry from BHU Banarasi. As a dedicated educator, he has taught and mentored students and residents and has also headed the department and institution at many prestigious medical colleges in Odisha and Chhattisgarh, having held positions such as Director, Professor, Head, Department of Biochemistry, JNMMC Raipur, Additional Director and Dean, Medical Education, Directorate of Medical Education, Chhattisgarh, Raipur, Director General, Sickle Cell Institute, Raipur. He is the Chairman of Institutional Ethics Committee and key member of the institutional body at AIIMS Raipur. With over 30 years of teaching and research experience in biochemistry, Dr. Patra has established himself as an expert in the field. His prolific contribution include 91 publications with special emphasis on the study and research on molecular genetics of sickle cell disease. Today, Dr. Patra will share his insight on sickle cell anemia in Chhattisgarh. So I request everyone present, please give a warm welcome and a loud applause to Dr. Patra. Dr. Patra, please.
So, as Madam has given me 30 minutes, but I'll wind up within 20 minutes because I have to rush, and that is sorry, I beg excuse for it. That is the only thing I want to request all the organizer, whenever organizing any meetings, please keep in time. That is the unfortunate part sometimes we face in this. So, the sickle cell anemia is it is a genetic disorder, it's a Mendelian recessive conditions. And it is a point mutation disorders. And it is the one disorders known very thoroughly. Or it is the first disorder known molecular biology also. It's first reported in 1904 and first journal come in 1910. And you see, it took more than 100 years to recognize the sickle cell is a health problem throughout the world. It was recognized in 2008 by the United Nations. I was invited there as a guest there. And then only I'll show you one slide because of this time problem, because I'll show you one slide. Up after the government intervention, how the scenario of any problem is changing. That is also now we have realized our Honorable Prime Minister when he talked about sickle cell disorder in 2014, now so many scientists, so many institutes are now working on disorders. I told it is a point mutation disorders where in the hemoglobin molecule, the globin, this protein, in the sixth position glutamic acid is replaced with the valine. Because all are in biochemists, you know how the charge of the amino acid is very much important for a configuration or a biological importance of this. So once the glutamic acid is replaced with the valine, glutamic acid is the negatively charged amino acid replaced with the valine, it is a positively charged amino acid, rather neutral amino acids. So once it is removed, this glutamic acids, the protein hemoglobin is in the sickle cell, it's relatively acting as a positive. So what happened? Out of this hemoglobin molecule containing sickle hemoglobin, this RBC become more sticky, it adhere to the endothelium, and in the deoxygenated state, that is the picture you see in the 100% oxygenation, that hemoglobin molecule remain discrete, and when the deoxygenated, when it becomes sickle, it become more adhesive because the RBC, the cytoskeleton is altered. So I was thinking that I will tell details about the molecular pathology, but I am skipping this, please excuse me, because this though it is a point mutation disorders, in a single point it is altering, it creates very clinical havoc, you can say, all the body from head to all organs involved in these disorders. So that is a one slide I am to explain. That I told this point mutation disorders, hemoglobin molecule is altered, after that the cytoskeleton is altering, mean the RBC membrane is altered. So this is the slide where you see in the right side, you please go through whatever the clinical or treatment mode is now going on. So you see the genetic disorders, no permanent cure is there unless until the bone marrow transplant or as the Das madam was telling about the CRISPR gene editing methods. So we are the group in India working on CRISPR gene editing, where the government of India has approved us for the clinical trial of the gene editing. So the one point is the either bone marrow transplant or is the CRISPR gene editing. So CRISPR gene editing is in the trial stage. Then next is the SBS polymerization. I told the hemoglobin when it is altered to sickle hemoglobin, so charge is altered, so hemoglobin molecule become more sticky, so it's in the deoxygenated state, it polymerize and form a rod-like structure. Imagine in a spherical structure like RBC, you put a rod, so it make a straight and curved, so the sickle shape. That is why the sickle cell anemia is named so. So the group of medicine now is targeted to reduce the polymerization. That is the one phase. Then another mode of treatment is vaso-occlusion. Because the more adhesiveness, this hemoglobin containing, that is the sickle hemoglobin containing RBC more sticky, so endothelium either, so that microvasculature is occluded, so the organ damage occurs. So another mode is to reduce this endothelium stickiness. Another is the inflammation, because due to the inflammation, so many disorders they generates inside the body and the organ damage occur. So another mode of treatment is the inflammation, to reduce the inflammation. So these are the target we use, and the most commonly I told this polymerization reduction, that is the hydroxyurea commonly used. This hydroxyurea, it is a myelosuppressive medicines which is used in the 50 milligram per kg body weight in the leukemia patient. But here in the, it is an accidental discovery again, and due to the CSIR in India also, our group, it officially now that approved, that FDA approved, is US FDA approved. Here in India also, the DCGI approved this hydroxyurea in use of sickle cell anemia. It's a very cheap medicine, and it is almost in the government of India and the different state government. I think in the Jharkhand also, the government has now distributing hydroxyurea in the sickle cell homozygous patient for the prevention of the complication, because here we are usually use 10 milligram per kg body weight to the sickle cell patient, so that the patients are remain clinically symptom free. So I am rest of these slides, I am excuse me, I am just skipping out. This is the very important strategic management of the sickle cell anemia. It is a genetic disorders, nothing to do with, because you know ये जो बात है ना क्रिस्पर और बोन मेरो ट्रांसप्लांट, हम लोग सब सोचेंगे सबको हम जो बोन मेरो ट्रांसप्लांट क्रिस्पर्स देंगे, so that's not a possible, and there is no need. My one point to request you all this, there is no need. Almost 10% of homozygous sickle cell patients, they do require the bone marrow transplant or this CRISPR gene editing like modern treatment. Rest of the cases, the patient very good is the responder. It responds to the hydroxyurea and the folic acid and the symptomatic management. So only thing you have to careful to the patients to you have to approach. That is why the screening is very important. I started the sickle cell screening work in Chhattisgarh, that is in 2004, and officially we started a project in 2007. But in sickle cell I started working in the, when I was third year MBBS student with our professor Dr. B.C. Kar, he was a professor of medicine. I started working there. So screening pattern is, you have to do the neonatal screening, is very important, because this has to be target for the treatment is the very early. Then the antenatal training from the all the screening has to be done to the antenatal mother, so that you can guide those. They can choose for the not to have a sickle cell homozygous child, so that you can guide the prenatal diagnosis are available now. Then one is the regular screening, those who will come to your hospitals, you can screen for the sickle cell. Then screening, after that homozygous and heterozygous you segregate, because it is a Mendelian recessive condition. Heterozygous patients don't require any treatment, they require counseling, because marriage counseling and genetic counseling is required for the heterozygous patients. Because our patients are ignorant, you have to be sensitize them. This is my experience is when I started screening work in Chhattisgarh, the individual, the society leader was snatching my car key. Arey bhai, tum kyun aa gaye? It is a social stigma they feel. So the sensitization is very important. Here also in Jharkhand, there may be same problem, because we had a project on CSIR, but I could not came and started. But from Chhattisgarh we started in Mandla, that is in Madhya Pradesh. But that was my zone was in Jharkhand also, but I could not come. But I started doing some work, but it was not very much encouraging. Anyhow, now the government is now started, I think Jharkhand government has started the working on sickle cell disorders, and now the Prime Minister has started the program that all the tribal population has to be screened. More than 10 crore sample has to be screened now. That is the screening method. I was the chair in this screening techniques, but there the mode what I will tell you, that was not used there. That is use the point of care testing, that what Das madam was telling about. The point of care testing is very important, though it is costly, but it is easy. You cannot be that your method is आपका सही है करके तो हम नहीं कर सकते ना. It is after all it is a science. You have to admit that point of care testing is a very convenient, though it is a costly method. So this screening is very important, and the routine treatment I am skipping. Yes, I am telling about this slide. So that is, you see, in 2000, after the 2008 only, on the sickle cell anemia, so many pharmaceuticals, so many government organizations, so many NGOs has come forward to help the sickle cell patients. As Jayasri madam was telling about, पात्रा तुम ये जरूर बोलना, हिंदुस्तान में तुम जब काम कर रहे थे, हिंदुस्तान में सिकल सेल में कोई नहीं काम कर रहा था, एक दो लोग काम कर रहा था. It is very true, because madam was our senior, as a veteran professor, he was telling that you please emphasize this point. In India, when I organized an international meeting in 2010, I could not find a speaker from India. There was one or two faculty I found for the sickle cell, because it is happy as a sickle cell worker after our honorable Prime Minister told about that sickle cell anemia is a genetic problem and that is the health problem, and the 2008 the United Nations recognized it is a health problem. Then only all the organization, on scientific community, all the pharmaceutical division, they started doing this research. That is a very important slide, because I have shared this slide. You can please go through it. It's a very important slide, those who work on the sickle cell piece. And this sickle cell hemoglobinopathy is found all over the world. And here in India, you will find in the central part of India, this type of hemoglobin disorders or genetic disorders are very much concentrated there, both sickle cell anemia and G6PD. This is the ICMR statistic, it is not my statistics. And one important, as a biochemist, I want to say, this is the heterozygote superiority. You might have known that this hypothesis is there in heterozygote sickle cell anemia, the falciparum is very less severe. Similarly, in G6PD gene, having the cholera is less severe. That is the hypothesis. This is known as heterozygote superiority. So, but this is not very true. As a worker, we have seen in sickle cell heterozygote also, the sickle cell is very severe there also. In India, 1952, it was the first case reported in the Nilgiri Hills. That was a tribal population, unfortunately, and gradually it is stamped it is a tribal population disorder. Yes, there it is a tribal population problem, but in Chhattisgarh it is just different. There tribal is there. In affluent society, in the OBC category is also very high. 30 to 40% prevalence is there in Chhattisgarh. So it is not confined. I mean to say, the sickle cell genetic problem is not only confined to the tribal population. This is the page I want to emphasize. So in 2007, I started in sickle cell screening work in Chhattisgarh with the help of the government of Chhattisgarh. That was total fund was given by Chhattisgarh government, that is to 2007 to 2017. Every year near about 1 crore rupees was funded to me, and the patients were totally screened. I was screening the school going children, that is the 3 to 13 years. Every combing operation, because that is the only tedious part, because no scientist is very interested to do this combing operation, because it is a heterozygote, there is a Mendelian recessive, heterozygotes are बिल्कुल फ्री है डिजीज. सो वो लोग क्यों आएगा आपके पास, डॉक्टर के पास क्यों आएगा? But they are the potential threat to propagate these disorders. So you have to detect the heterozygote and counsel them. That is the important part. That is the my aim and objectives of the study, and to detect these homozygous very early and give this treatment, that folic acid and the supportive treatment, the hydroxyurea, so that complication can be prevented. I convince the government of Chhattisgarh and the government convince. It is, you know, as an academician, you see, it is very difficult to convince the bureaucrats. And fortunately, unfortunately, I was with the additional charge as additional secretary to the biotechnology government of Chhattisgarh. So with this advantage, I could convince. Madam can realize this. It's very difficult to convince the bureaucrats. It's my experience, and but nothing to do. Which is our country, our setup. So you have to convince them. After all, they convinced, and we did it. And that from 2007 to 17, almost 20 lakh sample I screened, and every patients, the school going children are screened. The all data is with me now. Also, you can very often checked and cross-checked. So strategy was the block, every block I select, my team stayed there, and from the block to the panchayat, the village and school. So my team constituted of one driver. There were 10 teams working on. So one team constituted of driver, 2 technician, 1 attendant, and 1 cleaner. So this team with a counselor. So prior to the day of screening, my counselor visit the school and sensitize the teacher and give the consent form, because it's a genetic disorder, you have to take the consent. So the consent you have to, the form are distributed prior to 1 days, and the school children next day he brought, and then if they usually not signed, so many parents are not very much keen or so many interested and illiteracy. So we request the teacher to sign the consent form on behalf of the parents. So we collect and we do the solubility test, hemoglobin solubility test. It is one of the very cheapest, though it is little bit problematic, you can say, in comparison to the point of care testing, but it's very simple, very cheap. I have published 10 lakhs data in a Springer journal that it is the world most cheapest method of the screening of sickle cell disorders, combining the sickle cell solubility test and the cellulose acetate electrophoresis. So this is a gold standard methods, because so many things you might have heard, the HPLC, other things are needed, I am not denying, but if you will combine solubility with the electrophoresis, you can, your purpose is solved. Because you want to segregate the homozygous and heterozygotes, you have to counsel the heterozygote, and to homozygote you have to treat. That is the purpose. And those patients having received any transfusion, this solubility will not work there. So in that case only you can send for the PCR. So we do the PCR, but my purpose I never tell, because otherwise excuse जो बन जाता है ना, अरे हमारे पास तो PCR नहीं है, हमारे पास HPLC नहीं है, हम वेरिएंट कैसे निकालेंगे? जरूरत नहीं है भाई, आप do the solubility test. When once I came to the Jharkhand also, this was the same problem they told in the Jharkhand. मैं बाबा solubility करिए और electrophoresis कर लीजिए. That's enough. That will solve the problem. HPLC and other molecular diagnosis is not needed for instant segregation of homozygous and heterozygotes. That I want to emphasize you. That is nothing what is the DESI hematology is given, that hemoglobin solubility test, that is a high molar phosphate buffer solution in alkaline medium. If you put the sodium diethionate, which is a buffer, there the sickle hemoglobin will precipitate. That is the principle, very simple method. The twist I did is the sodium dithionate. I didn't put the sodium dithionate when buffer is prepared. What I did, rest of the buffer was prepared, pH was checked, and dithionate crystal I added in the spot. So modifying this, I bypass the cold chain method so that my stability of the buffer increased and there is no need of fridge. हम गांव में जाएंगे, फ्रिज कहाँ से मिलेगा? There are so many problem. नहीं तो वो एक बहाना बन जाता, हमारे पास तो फ्रिज नहीं है. So I twisted this way. This is the only my that was the, you can say it is my patent. I have not claimed for the patent. Yeah, that is, you can say, yes, Dr. Lahara is telling it's my initiative. I twisted this method and that I bypassed the cold chain. And there is no need of very trained manpower. कोई भी मैं भी इसको बिल्कुल सस्ती manpower से I did it and I did 20 lakh sample. मैं एक आध sample नहीं किया हूँ. ये कोई theoretical नहीं है. मेरे पास सब records है. You can verify even till now also. So all records are kept because this is a very important method. I twisted it and very cheap. It is a 2 rupees only cost solubility test. And these are the things, you know it. I am skipping it. Another modification I did in the cellulose acetate paper. The cellulose acetate paper, again you know this is a आजकल थोड़ा मिलने में प्रॉब्लम हो रहा है, बट मेरे पास तो अभी भी है. सो सेलुलोज एस्टर स्ट्रिप जो है, ये जो इतना बड़ी इलेक्ट्रोफोरेसिस रन करने के लिए अगेन प्रॉब्लम हमारा वही बहाना, एसी नहीं है सर, टेम्परेचर बढ़ रहा है, डिनेचुरेशन हो जा रहा है, हम फिर क्या करें. सो आई मॉडिफाइड वेरी स्मॉल, आई फैब्रिकेट वेरी स्मॉल इलेक्ट्रोफोरेसिस टैंक and the cellulose acetate paper. I want to know only the homozygous or heterozygotes. That was my purpose. So I did with a very little bit twisting method. This is the cellulose acetate paper in the picture you see. So इसको मैं ऐसे twist कर दिया. So horizontal I put. So एक strip को दो टुकड़ा करके मैं 20 सैंपल का एनालिसिस कर देता था. तो इससे मेरे को ओनली होमोजाइगस और हेटेरोजाइगस पता करना है, बाकी कुछ नहीं चाहिए मेरे को, क्योंकि उसी से सर टाइम सेव हुआ, बफर की स्टेबिलिटी बढ़ गई. सबसे बड़ी जो बहाना हमारा रहता है ना, जो एयर कंडीशनिंग, आई बाईपास द, बिकॉज स्मॉल टैंक, बफर इतना थोड़ी सी है, टेम्परेचर इतना कम जनरेट हो रहा है, डिनेचुरेशन नहीं हो रही, हमको एसी की जरूरत नहीं पड़ रही है. So with this technique, I have almost till now we are doing in our lab. There is no need. मेरे को 2000 रुपया में फैब्रिकेशन किया इलेक्ट्रोफोरेसिस टैंक, तो ऐसे में 20 टैंक बना लिया. मेरा 40,000 में 20 टैंक बन गया. तो मेरा और जो छोटी पावर पैक हम मिल जाता है 1000-1500 रुपया में, तो इलेक्ट्रोफोरेसिस टैंक मेरा बन गया. तो इसीलिए सो आई कुड डिड इट एंड वेरी इजीली, एफर्टलेसली. और मेरा इतना पर साल मेरे को गवर्नमेंट 1 करोड़ रुपया देता था, तो ऑलमोस्ट मैं 2 से 3 लाख पेशेंट्स का जो है इंडिविजुअल का स्क्रीन करता था. वो मेरे इतना पैसा में हर चीजें इन्वॉल्व करता था. कम से कम 70 स्टाफ काम करता था और 10 गाड़ी चलती थी, और पूरा लॉजिस्टिक्स से लेके बफर से लेके एवरीथिंग फॉर स्टोरिंग ऑफ द एवरीथिंग वाज इंक्लूडेड. सो इट वाज अ वेरी चीपेस्ट मेथड. आई रिपोर्टेड इट in the international very big reputed journal, and all international platform also appreciated. So that was the only point I want to emphasize. Rest of the things sir, आप veteran हो, senior, आपको क्या समझाए, हम पढ़ाने आपको नहीं आए, मेरे को ओनली इस इंफॉर्मेशन देने के लिए मैं आया था. सो आई डिड इट एंड आई रेस्ट ऑफ द स्लाइड जो है ये मेरे डाटा है, ये मैं ऑलरेडी बोल रहा हूँ इतना लाख सैंपल, और मैं एक जीपीएस टैगिंग भी किया था। जो पेशेंट्स जितना रेड पॉइंट है वो पेशेंट्स उस गांव में इतना जो है होमोजाइगस पेशेंट्स है, तो मेरे को इसको फॉलो अप करने में इजी होता था। मेरे कम से कम 6000 पेशेंट जो है रिकॉर्डिंग में है मेरा, और वो लोग रेगुलरली फॉलो अप में आते हैं। और 2010 में मैं इंटरनेशनल मीटिंग कराया, जो कलाम साहब हमारा चीफ गेस्ट थे, वहीं से सिकल सेल इंस्टीट्यूट की कॉन्सेप्ट वो डिक्लेयर किए, एंड 2013 में सिकल सेल इंस्टीट्यूट बना, मैं उसमें फाउंडर डायरेक्टर था। और जेहेतु गवर्नमेंट सर्वेंट हूँ, मेरे को 2017 में फिर मेरा को डीन करके चेंज कर दिए, ऑब्वियसली मैं वहाँ से हट गया। तो यही मेरा पर्पस था, यही मैं आप लोग को रिक्वेस्ट करने आया हूँ एज ए सिकल सेल वर्कर, नॉट एज ए बायोकेमिस्ट। प्लीज डू इन ए वेरी स्मॉल इन्वेस्टमेंट में सिकल सेल मरीज को आप हेल्प कर सकते हैं। हमारा ट्राइबल कम्युनिटी यहाँ भी, छत्तीसगढ़ जैसे यहाँ भी एक ट्राइबल डोमिनेटेड स्टेट है, और यहाँ प्लीज करिए। और ये जो पॉइंट ऑफ केयर टेस्टिंग तो ठीक है, जिसका पास पैसा है आप करिए, नहीं तो आपका 5 रुपया में इलेक्ट्रोफोरेसिस हो जाता है सेल रजिस्टर्ड पेपर की, 2 रुपया में आपका सॉल्युबिलिटी टेस्ट हो जाता है। आपका हर चीज़ 7 रुपया में, अभी 10 रुपया भी ले लो, 10 रुपया में यू कैन हेल्प टू द पेशेंट्स। So that was the one I was telling about. The Kalam Sahab was the one of the chief guests that time, and this was the concept I gave to the government of India as a different chairman. जे भाई ये comprehensive sickle cell institute होना चाहिए, और क्योंकि ये लोग बहुत ही जो है साय पेशेंट रहते हैं, हमारा बहुत इंट्रोवर्ट रहते हैं, ना जाते हैं ना बोलते हैं कुछ करते हैं, और ऐसे ही मर जाते हैं। तो उनको हेल्प करने के लिए गवर्नमेंट ऑफ इंडिया को मैं एक कॉन्सेप्ट दिया था। ऑलमोस्ट दीज आर नाउ ऑलमोस्ट इन प्रैक्टिस नाउ डेज। सो दीज आर द CSI are also help me different projects. So these are the counseling material I gave to the ASSS कार्ड। अभी तो गवर्नमेंट ऑफ इंडिया एक डिजिटलाइज कार्ड दे रही है, वो इजी है, एडवांस है, उसके कम्युनिटी में ये सब काउंसलिंग ये बड़ा छोटी चीज़ें है। पानी ज़्यादा पीना, धूप में नहीं आना, छतरी लेना, इस टाइप का छोटी छोटी चीज़ें। और जो स्कूल टीचर को बोलो जो भाई जो बार बार बाथरूम जा रहा था सिकल सेल पेशेंट को, उसको डिस्करेज मत करे, क्योंकि उसको पानी वो पिएगा, नहीं तो पानी नहीं पिएगा। And hydration is very important, because paucity of time I was interested to tell how the hydration is helping in the RBC cytoskeleton. Only पानी पिलाइए और पेशेंट्स को बहुत सारे बेनिफिट हो जाता है। ये तो काउंसलिंग मटेरियल आप लोग को मालूम है, ये सब बुक्स मेरा द्वारा लिखा गया था। ये ऑलमोस्ट आई वाज जस्ट ए कंपाइलर, एंड ऑल्सो आई गेव एवरीथिंग टू द गवर्नमेंट ऑफ इंडिया नाउ इन द प्रोजेक्ट्स। These are the counseling material, and ये मैं emphasis देना चाहता हूँ, simply addressing the patients, early diagnosis, early screening करके। ये जो डेथ्स जो है, पहले हमारा 10 से 12 साल में मर जाते थे, आजकल वो 50 साल तक आराम से जीता है। That was the average sickle cell patients की डाटा है। So thank you very much. So I am sorry I could not give you the full justice to the time. Yeah, please, madam, please, I. Yes, madam, thank you.
ओरिजिनल वर्क से तो जाएगा आर्टिफिशियल इंटेलिजेंस में।
Yes, madam, yes. Yeah, I am also thinking for it, because so many projects, because ये टाइम बहुत इम्पोर्टेंट है। अब मैं सॉरी हूँ, मेरे को एक इंटरनेशनल मीटिंग में ज्वाइन करना है नागपुर में, तो इसीलिए मैं हड़बड़ाते भाग रहा हूँ सर, इसलिए माफ़ी चाहता हूँ। थैंक यू सर। Yes, almost 10% prevalence is there in tribal community. Almost 10%. In our state it is 10%. 20 lakh sample में almost 2 लाख कैरियर है, और उसके 0.5% जो है वो होमोजाइगस है। ये डाटा है, it is established in छत्तीसगढ़। अभी तो NRHM, अभी क्या है, अभी इट इज ए, यू कैन से इट इज ए गोल्डन टाइम फॉर द सिकल सेल पेशेंट्स। तो मेरी रिक्वेस्ट है सर, आप लोग प्लीज काम करिए, उस एडवांटेज को लीजिए जिसने प्राइम मिनिस्टर के जो विजन है सिकल सेल को हमको 2040 से, ये तो थोड़ा ज़्यादा है, एज ए एकेडमिशियन हम नहीं बोल सकते हैं, 2047 तक तो सिकल सेल को उन्मूलन हम नहीं कर सकते हैं, क्योंकि इट इज जेनेटिक डिजॉर्डर्स। इट टू के 50,000 साल लगा यहाँ तक के आने में। ये जो जीन की इवोल्यूशन इतना इतना इजी नहीं है, लेकिन एज ए एकेडमिशियन हम नहीं बोल सकते, एज ए पॉलिटिकल स्लोगन वो तो पॉसिबल है, दे कैन डू एवरीथिंग। बट ये अच्छी बात है प्राइम मिनिस्टर साहब के बोलने के बाद सिकल सेल में जो काम इतना गति आई है, और दे हैव टारगेटेड ऑल 10 करोड़ जो ट्राइबल पॉपुलेशन स्क्रीन होना। आपका छत्तीसगढ़ सॉरी झारखंड में जो अर्जुन मुंडा जी जो ट्राइबल मिनिस्टर से, उनके साथ भी हमारा काफ़ी, हम उनसे वो मैं फ़ायदा लिया हूँ एज ए गाइडेंस देने के लिए। सो एज ए वर्कर मैं पर्सनल फ़ायदा कुछ नहीं लिया हूँ माननीय मंत्री महोदय से उस समय, बट एज ए चेयरमैन आई recommend for the screening of all the tribal population. That project started. So ये मेरे लिए बहुत खुशी की बात है एज ए वर्कर। थैंक यू वेरी मच, थैंक यू। तो ये सब चीज़ें में मैं नहीं जाना चाहता हूँ, बिकॉज द गैजेट इज वेरी इंपॉर्टेंट। हम इंडियन ये यूरोपियन एंड अमेरिकन को नहीं समझ पाते हैं। दे आर वेरी एन इंटेलिजेंट बिजनेसमैन, वो अपना गैजेट बेचना चाहता है। मेरा भी लैब जो है बहुत ही सोफिस्टिकेटेड लैब है, सीक्वेंसर से लेके माल्डी से लेके एवरीथिंग मेरे पास पड़ा हुआ है। सेल शटर, HPLC, UPLC, कॉन्फोकल, आई हैव ऑल्सो ए वेरी बिग लैब। मेरा ये एक्सपीरियंस मैं आप लोग को शेयर करता हूँ, वो खाली सामान खरीदना के बाद है। हमारा बहुत सारे काम जो है हमारे छोटी छोटी चीज़ें में हो जाता है, वो करना चाहिए। ये बड़ी बड़ी चीज़ें बड़ी जर्नल से देख के हमको इसमें स्टिक नहीं करना चाहिए। वो ना मन घी होगी ना राधा नाचेगी, ये स्थिति में हम काम नहीं करते हैं। प्लीज़ डू वर्क। यंग साइंटिस्ट के लिए है, यंग बायोकेमिस्ट के लिए मैं ये रिक्वेस्ट करना चाहता हूँ, काम करिए, बहाना मत बनाइए। थैंक यू वेरी मच सर।
Thank you, sir. Thank you, sir. In your busy schedule, you have taken few moments and sharing your thought-provoking and eye-opener topic about the sickle cell anemia. Thank you for your session, sir. Thank you, sir.
I now request the chairperson to give a small token of appreciation to our respected guest speaker and chief guest. Thank you very much, sir. We really appreciate your expertise and valuable contributions to the field. We now request our organizing secretary to give a small token of appreciation to our chairperson. my pleasure to introduce our distinguished speaker, Dr. Himanshu Majumdar from Lal Path Labs, who will be sharing his valuable thoughts on the critical aspect of maternal health. Today's presentation focuses on biomarkers for pre-eclampsia screening and diagnosis. Pre-eclampsia remains a leading cause of maternal and fetal morbidity worldwide, and accurate screening is crucial for timely intervention. I request our chairpersons, Dr. Sandhya P. Gulia, Professor and Head of Department Pathology, Manipal Tata Medical College, and Dr. Swikriti, Professor and Head of Department Physiology, MTMC, to introduce our speaker.
Good afternoon, everyone. I am privileged to introduce Dr. Himanshu Majumdar, MBBS MD Biochemistry from Assam Medical College, Dibrugarh. He is the Deputy Head Clinical Chemistry and Biochemical Genetics, Dr. Lal Path Lab. He has more than 10 years of experience in clinical biochemistry and is responsible for validation of various tests and also for the assistance in research, evaluation and validation of frontline technologies at Lal Path Lab. He has expertise in clinical chemistry and immunoassays, autoimmune serology, electrophoresis, HPLC, mass spectrometry, spectroscopy, molecular biology, and lab quality management. He has delivered in talks in CMEs and conferences and has number of publications in his name. Now I invite Dr. Himanshu to start his presentation.
Good afternoon all, and thanks to the chairperson of the session for a nice introduction, and my sincere thanks to all the eminent dignitaries and the organizers for inviting me and giving me the opportunity to share the stage with such veterans in the field of biochemistry who has done a lot of research in our field. So without taking much time, I will like to welcome you for my session. We as Dr. Lal Path Labs has recently introduced a separate portfolio called ALCORD, which is a Center of Excellence for Reproductive Diagnosis, where we encompass all the tests that are required and useful for a woman during her reproductive period, during pregnancy, as well as after childbirth. So I would take the opportunity to introduce the team ALCORD from National Reference Laboratory, Dr. Lal Path Labs, Dr. Nimi Kansal, the Head of the Department of Biochemistry, Dr. Vamshi Krishna Thatam, Head of the Department Genomics and Cytogenetics, Dr. Leena Rawal, Principal Research Scientist, and myself. So preeclampsia, as already mentioned, is a very important condition, a very important reason or cause for maternal morbidity and mortality, as well as adverse fetal outcomes. Preeclampsia, if screened during proper time, can be managed very efficiently. The screening and diagnosis or the prediction of preeclampsia both are very important and has been advocated by many organizations including NICE, ACOG, Fetal Medicine Foundation, and so on and so forth. So first I would like to brief something about the screening of preeclampsia. Preeclampsia, as I have already mentioned, is a major cause of maternal and fetal morbidity. It complicates around 2 to 5% of the pregnancies, and worldwide around 50,000 women die every year of preeclampsia. An estimated 5 lakh babies also die due to complications of preeclampsia every year. Preeclampsia, as we all know, is mainly characterized by hypertension and features of multiple organ damage. But a diagnosis remains a challenge because the clinical presentations are highly variable and even a patient with severe disease can be asymptomatic. So before going into details of preeclampsia, first let us understand the different hypertensive disorders of pregnancy. It can be definitely preeclampsia, where there is a blood pressure elevation after 20 weeks of gestation with proteinuria and other systemic findings. If the blood pressure elevation is after 20 weeks of gestation in absence of proteinuria, we call it as gestational hypertension. There may be chronic hypertension which may be superimposed with preeclampsia during pregnancy, or the patient can have chronic hypertension where elevated blood pressure predates pregnancy. Meta-analysis of various randomized trials have shown that if treatment is initiated with a low dose of aspirin before 16 weeks of pregnancy, in the high-risk patients, we can have a significant reduction in the occurrence of preeclampsia. Several professional bodies, as I have mentioned, like FIGO, Fetal Medicine Foundation, ACOG and NICE also advocates that high-risk preeclampsia patients should be treated with low dose of aspirin. But the major challenge is to identify who are the high-risk pregnancy. As per UK NICE recommendation, the high-risk factors as they have enumerated are hypertensive disorders during a previous pregnancy, if the patient has any autoimmune disease, if the patient has type 1 or type 2 diabetes, if the patient has chronic hypertension, these are considered as high-risk factors. Any one of these has to be present. There are some moderate risk factors also enlisted by them, which includes nulliparity, age 40 years or more, pregnancy interval of more than 10 years, BMI of 35 or more, a family history of preeclampsia, and multiple gestation. Similarly, risk factors have already been also been evaluated by ACOG and WHO. As per ACOG, nulliparity, old age, high BMI, and assisted reproductions consider high risk. Chronic hypertension, chronic kidney disease, diabetes, SLE or other autoimmune diseases, preterm delivery, previous pregnancy with a preeclampsia history or a preeclampsia history in the first degree relatives. WHO or World Health Organization also says that a history of previous preeclampsia, diabetes, chronic hypertension or renal disease constitute a high risk factor for the coming pregnancy. These all that I have mentioned are the high risk categories, are the maternal factors, the history of the pregnant woman. If we consider only maternal factors as a diagnostic or screening tool for preeclampsia, then the detection rates are not encouraging. It has a detection rate of only 36, 33 and 29% for a gestational age cutoff of 34, 37 and 42 weeks with a 5% false positivity rate. So considering only maternal factors or the high risk history of the pregnant woman is not sufficient. There is a requirement for additional markers for screening. We have biophysical markers for screening of preeclampsia, the most important being the uterine artery pulsatility index. Because we all know the underlying mechanism for development of preeclampsia is basically an impaired trophoblastic invasion of maternal spiral arteries, and Doppler ultrasound is a very good non-invasive method for assessment of this uteroplacental circulation. Impaired placental perfusion, which is reflected by an increase in uterine artery pulsatility index, is associated with development of preeclampsia and can be used as a marker. But it has some limitations, like an accurate measurement depends on appropriate training of the sonographer, quality of the instrument, adherence to standard ultrasound techniques, and first trimester uterine PI artery measurement, PI measurement also is affected by numerous other confounding factors. Next important biophysical parameter that can be considered is mean arterial pressure, which is the average pressure in arteries during one cardiac cycle and considered as a better indicator of perfusion than systolic blood pressure. This is the formula for mean arterial pressure, but the requisite for calculating mean arterial pressure are preferably an automated device should be used. Patient should be in sitting position for at least 5 minutes. Both arms should be rested at the level of the heart. Appropriate cuff size should be used. 2 readings in each arm needs to be taken, and average of all 4 readings should be used to calculate the mean arterial pressure. So this is just a pictorial presentation of how the patient should be made to sit, and the blood pressure should be measured to assess the mean arterial pressure. So if we see the inclusion of biophysical parameters along with maternal characteristics, we can see that there is an increase in the detection rate. It goes to around 80%, 40% and 31% for 34, 37 and 42 weeks at a FPR of 5%, which is far better than inclusion of maternal characteristics alone. So moving ahead, what else can be included to get an even better detection rate at a same false positivity rate? Then comes the role of a laboratory, or us, the biochemists, are biochemical parameters. Most important being pregnancy associated plasma protein A, or PAP-A, which is a syncytio trophoblast derived metalloproteinase. It has an increased mitogenic activities of insulin-like growth factors, which in turn play an important role in placental growth and development. A low PAP-A, calculated as less than 0.4 mom or multiple of median, has been found to be associated with a lot of adverse outcomes, which may include mid-trimester miscarriages, fetal growth restriction, intrauterine fetal death, preterm birth, and of course preeclampsia. Another important biomarker for screening is placental growth factor, which is a glycoprotein member of VEGF family. It's produced by villus and extravillus cytotrophoblast. It has angiogenic actions, and PLGF levels are found to be significantly lower in patients with preeclampsia and HELLP syndrome. Important point is that a reduced level precedes at least 5 weeks prior to the onset of disease, so which makes it a very important and a useful marker for screening. Combining biochemical parameters along with biophysical markers, that is the ultrasound markers, arterial pressure and maternal characteristics, we can get an excellent detection rate of 96% at 34 weeks of gestation, and for 10% false positivity, and 93% for 5% false positivity rate. So if we compare the FMF algorithm with NICE and ACOG algorithm, FMF algorithm, which advocates incorporation of maternal characteristics, biophysical and biochemical marker, we can see a much better detection rate of almost 100% in 32 weeks and 75% in 37 weeks as compared to the other algorithms. So first trimester screening for preeclampsia, effective way of screening can be achieved by combining the maternal factors, biochemical markers and biophysical markers, and this can be easily done in combination with dual marker, because dual marker is a much commonly prescribed test by the clinicians or the gynecologists as compared to preeclampsia screening, whereas the preeclampsia screening can be combined easily with dual marker. The maternal history we require for a dual marker test and preeclampsia test more or less are the same. We measure PAP-A in both the tests, just adding one PLGF and taking some crucial ultrasound measurements like uterine artery PI, we can give the patient a risk calculation for both aneuploidy and preeclampsia at the same time during the first trimester itself. We as a lab offer a combined panel where patient can get both these conditions screened during the first trimester at a much cheaper rate than the individual tests. This is a sample report for a preeclampsia screening, which include all the important factors, and finally you can see the risk for early and late preeclampsia has been calculated by a validated software. FIGO in 2019 have also issued some guidelines which support the FMF Foundation standing that all pregnant women should be screened for preterm preeclampsia during the first trimester by combined testing with maternal risk factors, mean arterial pressure, uterine artery PI and placental growth factor as a one-step procedure. And after this combined screening, if the screening result comes out to be of low risk, that the risk is less than 1 in 100, the patient can be subjected to routine antenatal care. But if the risk is high, patient can be started with low dose of aspirin to prevent the development of preeclampsia beyond 20 weeks of gestation. So apart from screening, this holds good during the first trimester when we can predict or like screen for a pregnant woman for possible development of preeclampsia. But if somehow a patient misses the opportunity and crosses the 20 weeks of gestation where the actual preeclampsia develops, the time, what else we can offer as a laboratory?
tests are available for preeclampsia prediction also. As on today, the diagnosis of preeclampsia as per UK NICE guidelines includes two factors. One is hypertension, systolic BP beyond 140 and diastolic beyond 90 after 20 weeks of gestation, and in a patient with chronic hypertension, an increase in systolic BP beyond 30 or diastolic beyond 15 is considered to be hypertension in a pregnant woman plus proteinuria. If we consider ACOG guidelines, they include hypertension, proteinuria, and if the proteinuria is not present, any one of the following newly onset conditions like thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, cerebral or other visual symptoms. So this is the scenario of preeclampsia diagnosis, clinical diagnosis as of today. But problem is that preeclampsia can develop without any warning sign. In a study by Dewey and Shannon in 2015, they have found that approximately 38% of the acclimatic seizure occurred in patients without hypertension and proteinuria were documented. So the conventional method or protocol of using the hypertension and proteinuria only as a diagnostic tool or predictive tool is not sufficient. Current practice is often ineffective in identifying the asymptomatic cases. Here also comes the role of a biochemist or of a laboratory to identify two important markers. One, placental growth factor that I have already mentioned during screening, and another is soluble FMS like tyrosine kinase 1 or SFLT, which is an anti-angiogenic marker. It stops the functions of placental growth factor or PLG. Both act in opposite directions. So the ratio of SFLT to PLGF becomes an important marker. If we see the clinical and pathological features, because of various factors like immunological, genetic, environmental, during the asymptomatic stage, the placental malfunctioning starting to happen, the placental perfusion is started to get impaired, and gradually the SFLT levels goes up and PLGF level goes down, and during the symptomatic phase the patient develops the symptoms like hypertension, proteinuria and all other. So the entire clinical course or pathological course of preeclampsia can be divided into asymptomatic and symptomatic stage. Our target is to identify the patient even in the asymptomatic stage. As I have already mentioned, an increased ratio is linked to a reduced blood flow to the placenta. As the SFLT levels go up and PLGF levels goes down, the endometrium becomes sick, vasoconstriction occurs, and blood perfusion to the placenta is impaired. Preeclampsia risk basically occurs with an imbalance between these two factors. If the anti-angiogenic state is high, the risk of preeclampsia is high, or if the proangiogenic state is high, the risk of preeclampsia is low, and we can expect a normal pregnancy. In 2016, NICE recommended that SFLT-PLGF ratio, when used with standard clinical assessment and subsequent follow-up, shows immense promise to help diagnose or rule in preeclampsia in a pregnant woman who present with suspected preeclampsia between 20 weeks and 34 weeks plus 6 days of gestation. Now, who are the women who present with suspected preeclampsia during a clinician's clinical judgment? If a patient has new onset of hypertension, if there is aggravation of previous hypertension, if there is new onset of proteinuria or aggravation of existing proteinuria, or any of the following, either preeclampsia related symptoms like epigastric pain, severe swelling, visual disturbances, sudden weight gain, or preeclampsia related findings like low platelet count, elevated transaminase levels, uterine artery Doppler value, PI value beyond 95th percentile. These can be incidental finding for a suspected preeclampsia case. In such cases, SFLT-PLGF ratio can be used to conclusively rule in or rule out the upcoming preeclampsia. This ratio aid in the diagnosis and a short-term prediction with specific cutoffs which are different for the gestational age. The cutoffs that we use as a laboratory is 38 for both early and late onset preeclampsia, and 85 as an upper limit for early onset, and 110 for late onset preeclampsia. If the value of the ratio is less than 38, then the patient is not going to develop preeclampsia in the next week. If the value is in the borderline state, there is possibility of developing preeclampsia in the next 4 weeks. If the value is very high, then there is highly suggestive of preeclampsia. This ratio, apart from aiding in diagnosis, also helps in clinical management, because if we see during the routine visit that the SFLT-PLGF ratio is very low, the patient is in a normal condition, then preeclampsia is ruled out for 1 week. So we can subject the pregnant woman for a low intensity routine antenatal care. No need of like hospitalizing or go for an intensive care. But if the ratio is very high in the first place, beyond 85 for early onset or beyond 110, then possibility of preeclampsia is very highly likely, and so high intensity management can be done, like proteinuria can be checked daily, blood pressure can be measured at least 4 times a day, kidney function test, transaminase levels, bilirubin, electrolytes can be measured every weekly. Patient can be started with oral labetalol at least twice daily. So the entire management changes depending on one ratio. So this ratio can be used for helping clinical management as well. This ratio can differentiate preeclampsia from other hypertensive disorders of pregnancy. As you can see, the levels of SFLT-PLGF ratio are statistically significantly high in preeclampsia or HELP syndrome rather than other normal controls and other conditions like gestational hypertension or chronic hypertension. A high SFLT-PLGF ratio also helps to identify the high-risk adverse outcomes like placental abruption, elevated enzymes, low platelets, basically HELP syndrome, small 4A gestational low birth weight, and abnormal uterine artery Doppler. So one ratio, if used generously and along with appropriate clinical correlation, can help the clinicians in predicting preeclampsia, categorizing their patients to low intensity management and requirement of high intensity management, requirement of immediate hospitalization, or even planning for an early delivery depending on the levels and her period of gestation. So the motto of our lab under this ALCOT division is basically that with every newborn baby a little sun rises. So as a clinician, as biochemist, or as a part of medical fraternity, we should all join our hands for a healthy future of India. Thank you.
We are grateful for your time and willingness to share your experiences with us, sir. Thank you, sir, for an outstanding presentation. I now request our chairpersons to hand over the memento to Dr. Himanshu as a token of appreciation. I now request our speaker to please hand over the mementos to our chairpersons. Thank you, sir.
Good afternoon, everyone. I am Dr. Megha. I would like to request Dr. Rajiv Ranjan Sir, Secretary ACBI, Professor and Head of Department of Biochemistry at Nalanda Medical College and Hospital, Patna, to chair the session for our next guest speaker, Dr. Jayashree Bhattacharya ma'am, on menopause and coronary artery disease in women. Your support will help ensure a successful session, sir. I kindly request you to take our seats, please. Thank you, sir. I would request you to kindly introduce our distinguished guest speaker.
Good afternoon, everybody. Before we start the program, I would like to introduce Dr. Jayashree Bhattacharya, Madam. She has served as Additional Director General of Health Services, Department of Biochemistry, Lady Hardinge Medical College, New Delhi. She has also holds the esteemed position of Lead Assessor and Committee Member, NABL. Madam's impressive academic credentials include an MD in Biochemistry from Banaras Hindu University, an MBBS from Assam Medical College, Dibrugarh University. Her distinguished administrative career spans over 3 decades with notable positions including Director Professor and Principal of Vardhaman Mahavir Medical College and Safdarjung Hospital. Professor and Head at the
Enough.
Bus.
Enough.
Both.
Both ho gaya.
And also, she has been a very active member of ACBI
I joined
and a
ACBI.
past president.
I joined ACBI when I was first year MD student in BHU. So this is the first conference भी होता है, association भी होता है, पहले पता चला. Just slide, देखो. See, we are talking these days about artificial intelligence and all, but I'll be showing 2 basic studies which I did or my students did few years back. Those are little bit molecular and others, but from there we have never thought that this can be utilized into artificial intelligence. So later on, when artificial intelligence is coming, I'm telling my students, as I was telling Petra, if you are having data, use it for artificial intelligence. And your paper will be accepted and you will develop algorithm like cardiologist. For cardiologist will be using algorithm for everything. ये risk factor है, इसमें इतना statin लेना है, इसमें नहीं है, sugar के साथ ऐसा है. So we also can give that. When I came from, I have been always doing work on coronary artery disease right from BHU, from my MD days. So I was in GB Pant Hospital working in coronary artery disease. I came to Hardinge. So where are coronary artery disease patient watch? Either I collaborate with GB Pant or I try to do something in the medical college where I am in. So we started mainly targeting pre-eclamptic cases and menopausal cases. See, one fine thing, whenever I give this thing, coronary artery disease in menopause, somehow in our patriarchal society or maybe lack of knowledge or lack of telling others that women are also equally prone for coronary artery disease. And women are more prone because they don't develop angina. Men develop angina. For women after menopause, they don't develop angina, or even before menopause if they develop coronary artery disease, because it is all microangiopathy in women. So they will never have any sign symptom telling you that it is, I am having unstable angina, stable angina, and suddenly they fall on the kitchen with coronary artery disease. ये बहुत sad scenario है. मेरा phone में है, दे दूँ? मेरा phone में भी है, उससे ले सकते हो. In my phone, हाँ. some of the works we did. And I was basically working on nitric oxide. So if you see my papers and all, we worked on nitric oxide. This was 2 students. We are doing a lot of menopausal women because in menopause, estrogen level is low, and that is a very high risk for coronary artery disease. So we are doing many routine works and some thesis with little bit here and there, LDL ratio, AO. But then we thought, I always tell, even in scientific meetings, that I have always served only in service hospitals, never in institute. I studied from institute, but never did service in institute. But in a service hospital, if you want, after you do the basic thing, you can go deep and also do molecular. And I think everyone can do it. If we could do it, everyone can do it. Next. So we are doing repeated nitric oxide studies, and then menopause we did lot of lipid and all. Then these 2 studies I am showing here. This is study 1. These are very basic research. One girl did it. She had to stay back up to 8 o'clock in the night. Platelet nitric oxide cyclic GMP signal transduction pathway in menopause. So these are all, mostly menopausal gases are very difficult to get. So you have to take surgical menopause and natural menopause. Of course, those also now we can go for algorithm, which we didn't do that time. So excluded women with known risk for CAD. So that is, in this slide, the only important thing is that excluded women with known risk for CAD. Next. Methodology study group, 50 menopausal women, 50 premenopausal women, fasting, sugar and all those things were done. Lipid profile, apolipoprotein, those we have done in previous studies also. But here what we included it, cyclic GMP and platelet nitric oxide. Next. See, sometimes I tell, for us service hospitals it is difficult to get. Like cyclic GMP, it was very difficult to get those days. But we requested firms, if you tell them that if you please give us some, sometimes it is difficult to get the money. So if you request them, for my insulin work also, I used to request them, please give me the thing, we'll mention that we have taken from you. You have given us for research. So nitric oxide we could get enzymology method. That time we didn't have chemiluminescence, but we had to do 2-3 times. If you do simple enzymatic immunologic thing, you have to do 2-3 times. That's the thing. पहले पीछे results में जाओ. हाँ, methodology हो गया. Results. Postmenopausal women had significantly lower estradiol, which is expected. Plasma nitric oxide and cyclic GMP levels as compared to premenopausal women. P-value was very significant. Cholesterol, low density lipoprotein, cholesterol and apolipoprotein levels high and HDL level lower in postmenopausal women compared to premenopausal. Plasma nitric oxide, which is actually a vasodilator. Basically, nitric oxide is a double cutting sword. We use the property, we mainly looked at the property of vasodilator. Plasma nitric oxide showed significant positive correlation with estradiol and HDL level and significant negative correlation with ApoB level. This is the finding in this slide, that with ApoB बिल्कुल अलग हो गया हो. Next. बेटा. Result पे और है, आगे है. Study 1 में चलो. ये तो दूसरा स्टडी है. Study 1 में चलो. Study 1 आउट चलो. उसके बाद conclusion नहीं है. Study 1 conclusion. Menopause tend to down-regulate. This is the important thing. Menopause tend to down-regulate nitric oxide cyclic GMP pathway resulting in endothelial dysfunction. That is the root cause. This is a basic study. That is the root cause that it is showing coronary artery disease. The mechanism may be directly through estrogen receptors or indirectly through potentiation of dyslipidemia. So conclusion का एक word भी बहुत हो गया. So we did in a service hospital, we did routine studies, we did apolipoprotein BB, चलो routine हो गया. And Study 2, platelet function and endothelial, this is more molecular. That was signal transduction. These are similar, nitric oxide only. After that, more molecular, platelet function and endothelial nitric oxide synthase gene polymorphism in postmenopausal women. Same correlation of endothelial and platelet marker and endothelial nitric oxide synthase, ENOS. Mainly I worked on ENOS, which is endothelial nitric oxide synthase. The polymorphism of GLU298 aspartate gene polymorphism to assess coronary artery disease risk in postmenopausal women. Methodology almost similar to that. Last plasma nitric oxide PF4 were measured by spectrophotometric and ELISA studied respectively. ENOS gene polymorphism was by PCR and then RFLP. We didn't go for sequencing and all. My PhD students later on used to go for DNA sequencing, but not MD students because time limit was there. What we found, that the level of nitric oxide in postmenopausal as compared to premenopausal, there was a significant decrease. That means vascular endothelial dilatation is less. Platelet factor 4 levels reflects platelet activity in vivo. Levels correlated with nitric oxide and significant negative correlation observed in both cases and control group. So here also as a thing I'll tell, as we do biochemistry thing, we do mostly in vitro. If we talk with pathologists, they say आप तो in vitro कर रहे हो, in vivo क्या हो रहा है आपको तो पता ही नहीं है. By the time it becomes in vitro, there are a lot of changes. So here the platelet factor 4 shows the in vivo significance. Then frequency of G allele. G allele is the wild type. So there was then frequency of T allele. GGO genotype was found in 41 subjects. Actual culprits are GT genotypes and TT genotype. In our study, as this was a small group, we couldn't find any TT genotype, but we found GT genotype found in 9 subjects. So these are the more risk factor, and we could give this molecular level. These papers are already published in good journals. Next, last one better. Conclusion, study demonstrate development of coronary artery disease risk in postmenopausal women may be multifactorial phenomenon beyond hyperlipidemia and other known risk factors. CAD being a major health and economic burden, imperative to treat at the earliest and avertest course. Women with ENOS GLU298 aspartate gene polymorphism and low nitric oxide level should be periodically monitored for development of coronary artery disease. See, we did this basic study. That time, it is almost 10 years back. That time we never thought about artificial intelligence. Now one of this study 2 boy, he is doing an artificial intelligence. I said, सारे जितना मेनोपॉजल का काम है ना, उसके algorithm निकालो. As I was telling Dr. Pat. And then we can go for actually artificial intelligence. Artificial intelligence cannot be done unless you have got basic studies. Where from they will get the data? See, आप Google search करिए, कोई भी disease, you will be asked, this is the reference paper, and go to the original paper. So for artificial intelligence also after few days, they will tell फालतू में बात मत करो, मुझे actual paper दिखाओ, reference दिखाओ. हाँ.
नहीं, आपका artificial intelligence को मारो गोली, आपका perspective है और आपका natural intelligence है जो perspective को.
नहीं, मेरा तो time खत्म, अभी तो मेरा student सबको करना है. So all of you do basic studies, keep those data and develop algorithm from there. Go for artificial intelligence. Collaborate with 2 or 3 people. You will have enough data. And कोई मुश्किल नहीं है. So don't be scared of artificial intelligence. Without artificial intelligence cannot be done without basic research and proper papers. अभी तो सब चुप है, नया नया मेटा एनालिसिस हो रहा है. उसके बाद सब बोलेगा तुम ओरिजिनल रिसर्च दिखाओ, कहाँ से सब फालतू के डाटा दे रहे हैं. Thank you all. Thank you all.
Systematic analysis.
Thank you, madam. I hope you have driven something to all the people here. अपने नेचुरल इंटेलिजेंस को आर्टिफिशियली बढ़ाइए. थैंक यू मैम.
Thank you, ma'am, for your insightful presentation. Yes, ma'am, of course. Our esteemed chairperson, kindly extend a warm felicitation to Dr. Jayashree Bhattacharya.
आपने जैसे बरगा एसीबीआई की स्ट्रेंथ है, इनको के मुखर्जी सर, रमेश सभापति सर, सब लोग कितना मानते थे. कह रहे हैं कि मैडम को एक अलग घर बना हुआ है जिसमें कि अपना सुख सकती है.
नहीं, while I was repairing, I didn't leave my this thing. These are my earning over the years.
Yeah.
So I took them home.
Thank you, ma'am. As a token of appreciation, thank you, ma'am. As a token of appreciation, I request Dr. Prakriti Das to felicitate our respected chairperson. Thank you, sir. Thank you, ma'am. The conference will now adjourn for lunch. We invite you to join us at the Swarna Rekha Dining Hall. We shall reconvene after 20 minutes. Thank you.